of all, I'm sorry for delay because I am a Stephanie here because Dr. Mike supposed to be presided over this session, so he could not come. So now, Dr. Sahil, we can proceed.
Yes, sure.
Yes.
Good morning. I first of all welcome our chairperson, Dr. Sudhir sir, and I would like to call upon our panelist, Dr. Nilesh Kumar Gupta, and Dr. Jahan Khatib. On to the dais, please. Yes, a small introduction of the chairperson and Dr. Sudhir sir. Obviously, everybody must be knowing about him. SICS expert and a fan of SICS. Presently heading most of the work at Global Hospital at Mount Abu branch, and really kind and gentle-hearted person, ready to teach, ready to available beyond academics and all. And it's great to have you, sir, over here as a panelist. Dr. Jan Khatib already has given a good number of talks, and I'm pretty sure many of you must have heard about him. He is a consultant ophthalmologist at Khatib Eye Clinic and Perfect Vision Laser Center in Mumbai. Expert as goes by the name, he is an expert in cataract surgery, LASIK, and refractive surgery, and also handles glaucoma over here. MBBS, he did his MBBS from prestigious Seth GS Medical College and KM Hospital, and after that MS from Karnataka Institute of Medical Sciences. Other degrees which he hold are DNB, FICO, MRCS, FICO, and FICO in both cataract and refractive surgery. He has been trained in phaco-refractive and advanced anti-segment surgery from Lakshmi Eye Institute, Mumbai, and Moran Eye Center in Salt Lake, USA. So he has been multiple recipients. He has been recipient of multiple international awards and AIOS International Ophthalmic Award, TP Lane Award for the best paper, and YKC Pandit Award for the best paper at MOSCON 2020. I welcome Dr. Jain to the session. The next panelist we have is Dr. Nilesh Kumar Gupta. He is Joint Secretary of YOSI and a very active person and a very close friend of mine. And he is from KMC Manipal. He did and then JM. He did his MS from JNMC Belgaum and Lotus Hospital. He has been trained in retina at LEH Coimbatore and DH Patna at Dr. Satya Prakash sir, who has been my senior fellow at Arvind Hospital Pondicherry. He is now presently the medical director at Madhavi Netralaya in Era, Bihar. He has an innovative novel smartphone-based gonio imaging device which is called as Digis Pro, which has been awarded at multiple innovator sessions. He holds a special interest in academics and research and has authored around 90 published articles and presented more than 100 papers. He has been invited for both national and international presentations and conferences, and he has also been active in live surgeries in multiple various conferences. His current area of interest is mainly research interest in smartphone imaging and medical retina, and obviously followed by that he's been very active participant in organizing multiple sessions of YOSI, and I welcome Dr. Nilesh to the session. So we'll start with the presentations, and first I would like to just verify the speakers. Everybody is ready. Dr. We have a array of speakers over here. We will be presenting various different topics, and we'll be touching some crucial points like OSSN. We'll be having something about SLAT. We'll be discussing something about ROPs, and we'll be discussing majority about the innovator thing, which is smartphone-based imaging by Dr. Nilesh. So I think this session is not just about one particular thing. It's a kind of potpourri or a basket of multiple topics. I hope everybody is going to enjoy this thing. First of all, the first speaker, I would like to welcome Dr. Nilesh, and he will be presenting on his innovation and also as a journey of YOSI, innovator. Dr. Nilesh Kumar.
Thank you, sir. Rospan and Prashant sir for providing UC an opportunity to present a UC session at Rospan, and I'll I'll start the presentation by telling you something about UC. This is on behalf of our secretary, Dr. Karan Bhatia. So these are his slides in the starting. So UC is a registered society and is affiliated to both AIOS and ICO on official affiliation, and caters exclusively to the needs of ophthalmologists training under 40 years of age. So either they are in training or they have just passed the training but are below 40 years of age, and it acts as a bridge between the senior leaders and young ophthalmologists. So we start grooming the young ophthalmologist right from the PG days, so that they can take up leadership, both leadership and academic activities at a young age. So this is the current governing council. Dr. Sonal Kalia, who is the executive member of ROS, also is our president. Dr. Digvijay Singh was our immediate past president. He is from Delhi. Dr. Divakar Mishra is our vice president. He is from Lucknow. Dr. Karan Bhatia, the secretary from Meerut. Dr. Avnish Upadhyay is currently in Gurgaon. He is our treasurer, and I am the joint secretary. And these are our executive, and we have Dr. Zain Khatib over here, and Sahil sir has been an active part of most of our UC session, including the currently concluded our AIOS UC forum at Delhi in April. And these are our presidential working group. This was a brainchild of Dr. Sonal Kalia, where she made multiple groups so that each executive can have one thing to focus on, and then we can promote. So we have multiple academic activities going on, like we have monthly around 5 to 6 webinars, anterior segment, posterior segment, oculoplasty, then we have retina, specific on retina, medical legal aspect, then we have on finance and practice development. So every month we have a webinar on each of these topics. Then we have UC job portal where we try to connect the young ophthalmologists looking for a job to the centers, not only corporates but the private centers or smaller centers who want to expand themselves. And then we have our UC resident network, where we help them during exam preparation. So we try to provide them with notes and links from where they can learn about how to write answers and all. And then YouTube UC was a brainchild of Dr. Karan Bhatia and Dr. Nikul Star, and Dr. Zain Khatib is taking it forward, where we have various kind of videos, descriptive videos. There are teaching videos of FACO, SICS, then we have exam skill sets, all kinds of videos are available, made by young ophthalmologists. So there is a tendency to keep what they want to hear. So now coming to my journey as an EO innovator. So these are my disclosures. So gonioscopy is one of the most difficult clinical field to be acquired, and thus even majority of glaucoma cases in the glaucoma clinic is not performed at baseline. This is the letter of editor we wrote around just before COVID started. So in this letter to editor, we raised the question that most of the recent advances in anterior chamber imaging, the surrogate to gonioscopy, are not cost effective and not easy to perform. Raising a question is important, but finding a solution to it is more important. We innovated a novel technique using just a 4-mirror gonio lens and a smartphone, which was validated on 65 eyes and was published in Journal of Glaucoma and made it to the cover art. So you can see the quality was so good in the initial phase itself that gave us a boost to go ahead. So this is how it began. It began as a jugaad. This is the first ever image that was taken by DIGS Pro, and you can see the amount of improvement it required. The middle image is taken with a trial set lens plus 12 or 13 diopter of trial lens was used to act as a macro lens to allow for more details to be captured. And the last image, this is the macro lens that is available on Amazon. We pasted it on my phone, and then we start taking the image. This is a long way from what we wanted to achieve, but the path was always exciting. We have tried around at least 12 different combination of macro lenses setup before to achieve what we wanted. And once we knew what the setup looked like, then the prototyping started. The device slowly began to look like what we wanted, that is a decent product. Initially, starting from the first day, because of my mentor, It was a plan that we have to launch it as a device and not keep it as a jugaad. That is the fruitfulness of the journey. There have been more than 6 prototypes before we could find a solution that fits majority of smartphone and majority of Gonio lenses. Finally, the device, which started as an idea in November 2018, was shipped as a product that can be used by everyone in September 2020. That was 7 days before my DMB theory exam. And this entire journey would not have been possible without my mentor, Dr. Ashish Sharma, who is there in the photo. His own journey is an inspiration, and his guidance to prevent me from making the mistake that he had made as an innovator of MII RedCam has made the innovation what it is today. So today we present to you DIGS Pro, which I call as DIGS Pro, one of its kind frugal commercial device in process of patent application, which is compatible with majority of 2, 3, 4 and 6 mirror Gonio lens and smartphone with single or multi-camera setup. This is the device that is being set up for use. You can see it's a Vogue 4 mirror G4 lens with flange screwed on the adapter that is available with the Gonio. With the device, and then you can just snap fit your phone on the RedCam and start a normal camera app. We have an app also, but initially we used to take only with the normal stock camera app. Just as you apply your Gonio lens, you can use the lens with the adapter in place. Ask the patient to look straight. The segment attaches beautifully because it's the lock and key model, and just you take this flask and you can start taking Gonio images. These are few sample images using Vogue 4 mirror lens. These are few sample images using Ocular 3 mirror lens. These are the problem with 3 mirror is that you take one quadrant at a time and then you have to keep rotating and keep taking photographs. In the validation trial of the device, where out of 280 images, 89% were of credible quality. The kappa coefficient between the slit lamp gonioscopy and device was 0.65, and between two mask graded was 0.82, both implying substantial agreement. This paper was presented in last AIS in Kochi and won the best free paper of the session. This is the first, one of my junior, she did her thesis, and this thesis has been accepted by DNB right now, and this is the first thesis on the device that has been accepted, and she also has passed now, so she is a consultant. It is also a great education tool for the patient. Only 56% of the patient agree for YAG PI when counseled verbally. But when we compared with counseling using DIGS Pro, 93% of the patients agreed for prophylactic laser. That was the evaluation trial that done on 200 patients, and that is solely because they knew what they wanted to. When they walk into the OPD, they are not sure why somebody I just came for a reflection and asking for me to get a laser done. But when you show what is the problem, they immediately agree. What else? As we went ahead on the journey, we realized that the device use case went beyond what we intended. So when coupled with slow motion videography, the dynamic nature of angle can also be visualized in the anti-closure aspect in a more physiological manner, because what we know is angle starts constricting, and mid-phase you have to have this angle closure. So here you can see this. You can see on the superior side the angle is opening up. It is a closed angle. Once you flash, the pupil constrict and it opens up. So slow motion videography is another thing. Anterior segment, diffuse anterior segment imaging is another thing. It also doubles up as that, and a comparison between with companion MI RedCam app allows for easier record keeping, teleconsultation, and also gives us an opportunity to collaborate with various research projects. One of such project is to create a data repository using DIGS Pro, which will then be utilized by machine learning to create an AI overlay in the app. So immediately the technician will say this is a referable case for YAG PI to the hospital, and then further evaluation will be done as at the center. So should we stop? What all could have been done has been done with the device. The beauty of innovation is that it keeps evolving. The next frontier to achieve is on reflection-free images. We are now currently experimenting with various polarizers so that we can get a reflection-free 360-degree image, so that we don't have any blemishes on the image. Hopefully it will be available soon. And the core problem, that was practice of gonioscopy, is still not achieved. We are not able to achieve a gonioscopy where the resident can practice gonioscopy before going on actual human patient. So now we are developing a human eye where gonioscopy is possible. Right now, all practices are for fundus evaluation. Nothing is there for anterior segment imaging. anti-segment evaluation or gonioscopic evaluation. So that is our next product. Hopefully, we will be able to launch it in next 2 years because the cornea, what we want to replicate as a cornea is very difficult to achieve. But hopefully, we will. Thank you. Till then, keep imaging, keep innovating, keep translating, and keep digging.
Dr. Sai, congratulations, and this is what science and like youth can do the wonders because most of our senior ophthalmologists are busy with other things. So basically, that's why we should not. Basically, ophthalmology is for focusing, but we should also defocus. I mean, we should also defocus our goals. Beside ophthalmology, we should create innovations and Jugaad, Jugaad is done by illiterate persons. They have invented. So one thing you can also do with this posterior segment photography with this device. So have you tried for the posterior segment?
Sir, if the pupils are dilated, then we can take image of this. There are a few images of this that we have tried to take, but actually because my mentor Dr. Ashish Sharma had a posterior segment imaging device, so we didn't pursue that. But what both of us are thinking that we have to have a wholesome solution. We are starting from anti-segment to posterior segment with one device we can take. There is a possibility we have to have a rotatable lens where there is a separate lens for anterior and posterior segment, and we can achieve that.
That is available if you go by the old. Just try on the old golden three mirror, golden simple.
Yes, sir. This we took from that only.
Or miniatures focal laser or something like a pen or retinal lenses.
Yes.
So you should work on that. And one thing also causes the problem for the most of the Indian and Asian countries. So you for these three mirrors of gonio, so you should have your own like manufacturing or supplier for this to cut your cost.
Yes.
Because Madhu people are also just making good devices. But if you are so, this is now for any innovation. One is the idea, then I just was to just validate the idea. Then it's for like a prototype, and after prototype, then it's commercially viable or not viable. So I think it is commercial viable, and soon you can. Now I'll see you after. Now you are around below 14. After 40, you will be on top. Innovators
Thank you, sir.
and entrepreneurs like Sahil.
Dr. Zen, anything you would like to comment upon?
Uh, Congratulations, Dr. Nilesh. I've seen the Dix Pro, reach very great heights already. Just one question is, when you started this, you were a resident, right? What was the problem statement which made you start innovating on this?
I tried to counsel a patient. She was not at all ready to listen, completely closed angle, and she just, what I said, she wanted to, uh, uh, I wanted her to get a PI done, but she was like, I just want class, I don't want to do that. And this was a peripheral center. We had to travel around 60 kilometers twice a week to go to periphery and see the patients as a resident. So while coming back in the cab, then this thought process started that how can I do, and my initial thought process started with direct gonio lens. So you put a direct gonio lens and then make a distance, because that's what I saw with MI RedCap, that at a distance from with 20D you can take that image. So that was the first thought process. Then suddenly next morning I went to my gym. Right now I have stopped, sorry I'm doing this, but that time I was going to gym regularly. So I was taking a mirror selfie, and that struck me that when I am able to take a mirror selfie, gonio mirror is just a mirror. So then I started innovating, improving on that, and the whole journey.
So you wanted to basically image the.
Image the-
It was not to make the process of gonio easy, because the most biggest challenge is that people don't know how to do gonioscopy properly. So if your device would be something which would be easier than putting a traditional thing and seeing with your naked eyes through the slit lamp. So does it work in that sense, or the technical expertise needed is that much only?
The learning curve becomes slow. The main problem is not they don't want, because putting a gonio lens is very easy, but they don't know what to see. So once they start seeing, then they move on to slit lamp gonioscopy.
And all the four angles are seen equally well, equally focused in one
inferior mirror is little bit decentered, but then if
Three
you
angles
adjust,
you can see simultaneously.
three angles you can see.
I think that's a good teaching tool. What residents basically, when you show on the listener, so you can't pinpoint this part at this, but when it's photographed, then you can show to resident this part and then this part, and then the next time it's a teaching tool. It's good teaching tool. I think would be helpful for this, and that's a commercial available.
Yes, sir. We are selling for last 3 years around
Okay, and what is-
75 devices we have.
And what is the cost for this?
25,000, sir,
Without coding.
without the
Yes, fine.
So I have a question. What were the hardships you faced? Like, it's okay you think, but then how was your journey of that? Like, how did you acquire? Because sir, as an ophthalmologist, you're only taught to see, but how did you give, like the instruments, all these parts?
So that's where we have to think beyond ophthalmology. Once we start developing the product, then we had a production. My mentor had, so it was easier to connect, but it's not that difficult. You can get most of the vendors that are available online. So once you have an idea in place, so first thing is that you have to have your idea in place. What is the distance between your macro lens and your camera? The distance between your macro lens and your gonio lens? What type of gonio lens? So that all they want. They don't know the basics. So we can't give them this and then they have to figure out. So if that everything is in place, then what you have to tell them is this is the product, and production designers are there. They specifically trained in ITI and IITs for production design. So they take all the measurements and they make a CAD drawing. And once the CAD drawing, you feel that this is feasible. In the CAD drawing only you can have all the place moving left, right, up, down, everything. So if everything you feel is working good, then you ask them to make a prototype. Either it can be a plastic prototype or a metal prototype, depending on your budget. It was very costly for me. Each prototype costed me around 80,000, 90,000 rupees, and during PD time it was very difficult to be funded. My father helped me a lot. Total around 5 to 6 lakh was spent just on the prototyping. But if you have 3D printer, 30,000, 40,000 3D printer, and you can go ahead and start prototyping. Dr. John Davis Akara has a beautiful video on YouTube. You can see that how to do the prototyping. And once you have that, then you start thinking about other things. So first thing is what you are thinking. Is it working? Is the prototype stage. After prototype stage, it becomes very easy. There are multiple ways to you can approach companies if you don't want. If you want to market yourself, you can do it yourself. Also, make a website very easy to make nowadays.
We have like Dr. Nilesh is there as an innovator. We have Dr. Grover,
John Davis Akara.
John is there. One Dr. Grover also is there. Tushar Grover and his I think I forgot his name, but we have few people like ophthalmology. They are actively involved in all these. Especially John is there. They are actively involved in innovation, getting in contact with the companies, and especially they are now focusing on 3D printing. A lot of things they are focusing. So we can get in touch if like when you get some idea and all those things. So they help in channelizing that thing a lot. There are many people. I mean, directly
And now
companies.
AIO's think under the apple tree where innovations are presented. From this time, they have told that whoever is in the top 10, they will help them get connected. So if your idea is really good, then there are multiple ways right now to approach them.
I couldn't get it. What was your question? What?
She wanted to know how to
After idea, how it was.
Okay. Just. Yeah. I try to give you the answer. Basically, for the innovators, no, this is one type of love. Okay, between you and your innovations. रातों की नींद उड़ जाती है, right? जब तक कोई solution नहीं आता है ना, तो now you people are lucky. You are having everything. Technology is there. I am also an innovator. पता है मेरा इनोवेशन नहीं पता है सर. जस्ट मैं एक स्क्विड मास्टर सॉफ्टवेयर है. This is world's number one software. I innovated in 2008, and for that I learned Visual Basic. And the learning Visual Basic in computer is like it's more than the PG books this talk. So for innovations, just your idea is fine. Try to just get it. What is the utility of that idea? Rest is
That there is an Ikigai model. The Ikigai is the Japanese philosophy. So I apply that. Is your idea good? Do you only think that your idea is good, or the world thinks? And is the world willing to pay for it? If all three boxes are ticking, then only go for commercialization. Otherwise, not. So,
Thank you, Dr. Nilesh. Thank you, everyone, for a nice discussion over this topic. Now, I would like to welcome the second speaker, Dr. Sunaina Atila. She will be speaking upon OSSN. Dr. Sunaina. Dr. Sunaina. Yes, please go ahead.
Good morning, everyone. I'm Dr. Sunaina Hatila, currently working as senior resident in the Sardar Patel Medical College, Bikaner, and I have done my PG in the year 2022 from the SMS Medical College, Bikaner. SMS Medical College, Jaipur. I'm here to discuss about a case on ocular surface squamous neoplasia. First of all, conjunctival lesion can be pigmented or non-pigmented. The non-pigmented one can be benign, pre-malignant or malignant. Benign one can be papilloma, pedunculated or sessile, epibulbar choriostoma, dermoid or lipodermoid, and pyogenic granuloma. The pre-malignant one can be carcinoma in situ, conjunctival intraepithelial neoplasia, and the malignant one can be squamous cell carcinoma, Kaposi sarcoma, lymphoma, mucoepidermoid carcinoma, that is the most aggressive one. The carcinoma in situ is the non-invasive OSSN, and the squamous cell carcinoma is the invasive OSSN. Both of them are included in the OSSN category. So, well-informed written consent was taken from the patient. He was a 50-year-old male, farmer by occupation, came to IOPD with the complaint of mass in right eye since 1.5 months. That mass was initially millet size, then increased gradually progressively and becomes small pea size, almost 4 into 5 mm. It was diagnosed as intraepithelial hyperplasia in one center and as limbal nodule in the other center. No significant other complaint was there from the patient, that is no irritation, no itching. This was the picture of the conjunctival mass. The treatment given by the other centers were eye drop moxifloxacin 0.5% 4 times a day, eye ointment moxifloxacin, oral anti-inflammatory and oral antihistaminics were given to the patient. Eye examination was done and left eye was found to be within normal limits, and in right eye, other than conjunctival mass, there was no significant finding. This was the picture of the mass in which we can see that 5 mm was there in the horizontal and 4 mm in the vertical diameter, and the mass was present on the limbus encroaching upon the cornea. This mass was present in the interpalpebral area on the nasal conjunctiva. Few of the dilated vessels can be seen. So pointer is not there. Few of the dilated vessels can be seen, which are engorged, and these are seems to be supplying the tumor tissue, or this tumor tissue can be encroach upon the underlying structures. Other eye examination was found to be within normal limit. As well, the blood investigations were not any significantly different. And viral markers were also non-reactive. This was the staging manual that were used, American Joint Committee on Cancer 8th edition staging manual. This was the staging manual used for the staging of conjunctival mass. This is the schematic representation of the progression of OSSN, and this pink line represent the basement membrane. This is the normal tissue, this is the conjunctival intraepithelial neoplasia, this is carcinoma in situ, in which all the cells are found to be dysplastic, and this is invasive carcinoma, in which the cells are found to be invaded the basement membrane. Surgical excision was done with 4 mm free margin with no touch technique with the adjuvant cryotherapy at the base and margin. This are the surgical videos now. Excuse me, sir, for this. Actually, in surgical video, the mass was excised. Before that, calipers were used for measuring the 4 mm margin, and the 4 mm margin was marked with the help of dye. Excision was done with the help of cryotherapy probe, and after excision, base was also cauterized with the help of cryotherapy. And at the end, amniotic membrane was implanted. Histopathological report shows conjunctival intraepithelial neoplastic lesion with mild dysplasia on the impression, and in microscopy it shows papillomatous hyperplasia with mild dysplasia. So diagnosis was made as a tumor in situ with no lymph node involvement, no metastasis with grade 1 according to the AJCC TNM classification, and conjunctival intraepithelial neoplasia with mild dysplasia according to the Lee-Hurst spectrum. Differential diagnosis could be papilloma, but this papilloma is a benign tumor. It could be nevus, but nevus and malignant melanoma could be there, but these are pigmented ones, these are not non-pigmented. And it also could be pyogenic granuloma, but it is found to be benign. Postoperative treatment was given as eye drop mitomycin C 0.04% 4 times a day with 1 week on and 1 week off cycle for at least 1 month, or 3 to 4 cycles were given. This was the picture postoperative day 1, postoperative day 7, and day 30. Thank you. These are the references.
Thank you for the presentation, sir.
One small suggestion, I could not see your petition, but one small suggestion. There was a patient's name was visible in the slide. So that should be avoided, easily avoided. So no, any except age and something, other identities should not be. Okay.
Sorry for that.
No, it's okay for.
Dr. Nikhil, yes, please.
We just want to know. So just want to know whether you have done alcohol apiclectomy in this, or you were like because you have not done rose Bengal staining and any staining. So did you check for the involvement of the cornea also?
Sir, corneal involvement was actually, this thing was the limitation. I hadn't checked that, but alcohol was applied. I skipped that part as the surgical route is not.
So that would be like rose Bengal staining could have been done in this prior to the surgery.
Yes.
So that would have helped you to deal with the tumor cells.
Yes.
Second thing is you should have used interferon alpha 2b or some mitomycin pre-operatively also, because the tumor set is small, 3 to 4 mm I think. So it could have resolved directly with the help of this chemotherapy. Just
Thank you so much. Thanks.
Dr. Nikhil, my question, do you think in this kind of thing, presentation, amniotic membrane should be like placed in the primary surgery, or can we leave it bare sclera because not very large lesion as such?
leaving the bare sclera is never a good option for these type of cases. In fact, suturing it again back to the cornea itself, the limbus is also dangerous, because you never know if the margins you resected are positive or negative for the purpose. So if the margins for the tumor which you have resected are positive, then it will again spread to the limbus part of the video suture it, creating a bare sclera is itself a problem. So better is to go ahead with the with the amniotic membrane, because the size of the tumor is almost 3 mm. So you are going to take the 3 or 4 mm margin, so it will be around 7 mm. So you are going around 7 mm, creating defect of around of 7 a.m. from the labels. So better to cover it with the amniotic membrane. And results are also very good around increasing with the amniotic membrane. And that will,
Yeah, but fortunately, lesion is the, I think it's left eye, is right eye, left.
So right eye nasal margin.
Well, that's okay. So this quadrant is free from the muscles. Okay, inferior to this side, middle to this side. So for the downside, no problem of shape margins here. Cornea is most resistant even for the glioblastoma is quite resistant, and we have tissues available for the cornea like partial keratectomy and all that. And my experiences of doing all these lesions, and I never cover it did that lesion with conjunctiva or like amniotic membrane, because that heals beautifully, because our like conjunctiva is very generous, and it can come out. And I have posted some of my videos of even large excisions for hemangiomas, these OSNs and all this. And alpha 2 is quite good, yeah, I have suggested. So, but because it's available here, so next time, even for the youngsters, for Foxy, you should take over all these things. Otherwise, like you know, now, if you have, I am from Mount Abu, and Mount Abu is beautiful place. And what is happening? Sometimes this is the for Angrez that time. They brought the lentina. Lentina is for smoke flowering, but now all Mount Abu is covered by the lentina. So I want to say one thing, because for our economics and commercial activities and all that, ophthalmology covered by the cataract. So cataract is the lentina of Mount Abu. So for the Foxy, I think this platform is right platform. So these are the things. So and we can train our the budding ophthalmologist. So what I feel, science is science, and it should be mixed with the humor, and humor should be like a salt in your atta. And now what is happening sometimes, like atta is in namak in namak mein atta. So Foxy is doing wonder, and no sorry Foxy नहीं, मेरी वाइफ गायनोकोलॉजिस्ट तो मैं Foxy बोलता हूँ. But you see, so you are doing, and you should carry forward all these things, small techniques, innovations, gonioscopy, and these OSNs. And so if we can give the our junior budding right time, right suggestions, so they can do the, so, because they are going to teach us. है ना? So our juniors will be competent enough, so we can have faith on that they can teach us.
definitely, US is an important topic.
Yeah.
And definitely, the treatment which has been given prior to the start of the
Yeah.
treatment, it has been like said to see the moxifloxacin movement twice a day by some surgeon or some maybe optometrist. Better. Good.
So what did you get from this talk? Take home points. What you took from here?
So diagnosis is much more important, and
And two important point. Take home point from the like what was the name? Dr. Nikhil and us.
sir, he has said a very important and good thing that alcohol, absolute alcohol,
No,
should be used.
no. Just to be precise, I'm telling you, you should use pre-operatively this
So
mitomycin or
mitomycin.
that is very good. Sometimes you don't require oxygen.
Okay.
They do wonders.
Yes, sir.
And then one wonder is also there, propranolol for yeah, hemangiomas. Propranolol is wonderful drug. So all these things. Thank you very
Thank
much.
you so much.
Yeah, and keep on presenting. We present, then we read, then we discuss. So that is how our knowledge increase.
Thank you, sir.
Yeah.
Thank you, Dr. Sunena. One thing, just last one question. Did you do ASOCT for this case? I think that is the new major tool nowadays in ASOCT. And next time, whenever you get such cases, Dr. Nilesh, Dr. Zain, any comments, please? Okay, so we'll go to the next speaker. I welcome Dr. Ashna Chaudhary to talk upon COVID-associated keratoconjunctivitis. Dr. Nikhil, you will be using your laptop. Okay, so Dr. Ashna, please. Dr. Nikhil, AV, please set for next.
Good morning, teachers. I'm Dr. Ashna. I'm presently working as senior resident in SMS Medical College. I completed my post-graduation from SMS Medical College in 2022. I'm presenting the case series of patient with COVID-associated keratoconjunctivitis and corneal perforations with bacterial superinfection managed by conservative approach. So COVID-19 is an infectious viral ailment that primarily affects upper respiratory tract. However, it can involve other organs including eyes in the form of conjunctivitis. It gains access to the host cells by binding to the ACE2 receptors present in various tissues. In the eyes, specifically in cornea, conjunctiva, ciliary body, iris, and retina. Signs and symptoms are similar to those of acute viral conjunctivitis like conjunctival congestion, follicular reaction, watery eyes, periorbital rash, and edema. It can precede or occur with or without any systemic illness. It is usually duration lasts for 3 to 4 days and is a self-limited disease if not complicated with superinfection by other organisms. So here's the case history of a 13-year-old male patient without any significant past medical history presented in IOPD with diffuse redness in both eyes, photophobia, foreign body sensation, foreign body burning sensation, mild eyelid swelling, itching and excessive tearing with mucopurulent discharge for 4 days, more in left eye and diminution of vision. There was history of taking bath in pond 5 to 6 days back, after which the patient developed outer ear infection with pain, redness and discharge. There was no other history of any systemic illness. On examination, his vital signs were within normal limits. West corrective visual acuity in right eye was 6.6 and left eye was finger count close to face. Slit lamp examination of right eye showed conjunctival congestion within whitish and watery secretions, and in left eye, conjunctival congestion along with excessive watering and mucopurulent discharge were present with peripheral corneal thinning and diffuse corneal haze. This was a picture presentation, both the eyes showing conjunctivitis, keratoconjunctivitis more in the left eye, and outer ear infection was also present along with ear discharge. So this is a slit lamp examination of the right eye. The cornea was, at presentation, cornea was clear, only mild conjunctival congestion was present in left eye. Conjunctival congestion along with diffuse corneal haze and peripheral corneal thinning was present. Other parameters were within normal limits. Well-informed consent was taken from the parents, and the following investigations were done. Conjunctival swabs for culture and sensitivity reporting. Conjunctival tissue was taken for histopathological examination, and nasopharyngeal swabs were taken to rule out COVID-19. Patient was referred to ENT specialist for management of ear infection as well. Initial treatment in the form of moxifloxacin eye drop 6 times per day was given, and patient was followed up with reports. The COVID reports were found to be positive. The culture sensitivity report shows growth of Coagulase positive staphylococcus, which are sensitive to vancomycin, teicoplanin, gentamicin, doxy, linezolid, and chlorprimoxazole and clindamycin. Histopathological examination showed the fibroglacinous tissue with chronic inflammatory cell infiltrate. So the diagnosis of SARS-CoV-2 associated keratoconjunctivitis with bacterial superinfection was made based on the history given by the patient and based on the histopathological and the COVID-19 report. So disease progression after 7 days, there was worsening of symptoms in both the eyes and decrease in visual acuity, which was more in left eye. This was the picture at 1 week. Right eye also developed mild corneal haze along with slight thinning in the periphery. The left eye developed corneal perforations along with diffuse corneal haze. Later on, the left eye also developed prolapse of the iris tissue at the thinning. So in accordance with the culture sensitivity reports, patient was started on fortified vancomycin eye drop 1 hourly with cycloplegic, anti-glaucoma and lubricant eye drop, and was followed up weekly. After 4 weeks, marked improvement in symptoms was seen. The congestion and the watering and discharge decreased. Cornea became slightly clear, and perforation got healed along with reduced corneal haze. 45 drops were continued for 4 weeks. At around 6 weeks, cornea showed signs of bone healing, 45 drops were stopped, and lubricant eye drops were continued. This was the picture at 8 weeks after treatment. Right eye shows the cornea become clear and healing with scarring at the site of corneal erosions and thinning. Conjunctival congestion reduced, and in the left eye also healing occurred with scarring, and healing occurred at the site of corneal perforations as well. And the best corrective visual acuity after 8 weeks, 6.6 in both the eyes. So other cases of similar presentation. This was the case of 85-year-old male patient with prolapsed iris tissue. He was treated on the same line of management, and after 8 weeks, healing was seen. This was another case with similar presentation, but we lost this patient to follow-up. So in this patient, the initial progression of conjunctivitis it might be related to the proliferation of SARS-2 in the conjunctival sac by binding to the EC2 receptors. Later on, worsening of symptoms along with corneal perforation might be indicative of reactive disease, which may be because of cytokine surge. So, COVID-infected cells they express inflammatory chemokines. These liquids affect the leukocyte-specific tissues, and these leukocytes recruit more inflammatory cells. This production of inflammatory cytokines and cytokine surge occurs, and it results in the apoptosis of the epithelial cells of the peripheral cornea and reactive inflammatory agent. Recent studies also reported significantly high levels of inflammatory factors like granulocyte colony-stimulating factor, TNF-alpha, interleukin 6, and interleukin 10 in severely ill COVID-19 patients. So the proper use of glucocorticoids, it can diminish the cytokine surge, but they are believed to promote viral replication epithelial keratitis, so they are usually not recommended. But they can be used along with the antibacterial cover. In case of severe corneal inflammation, interleukin 6 inhibitors they can also be used. So we conclude with aggressive medical management intervention and longer and more frequent follow-up and proper use of antibiotics can successfully control the symptoms, and it can significantly prevent the blindness and mitigate the need to go for surgery later on. Thank you.
Nice presentation, Dr. Hasan.
Thank you.
So, my first question would be the other cases that you showed related. All their COVID positive.
Yes, sir. All four cases were COVID positive, and the third case had oral infection as well. So they were treated on same line of management, but the third patient he was lost to follow-up.
Yeah, but other two patients they had history of exposure
Yes.
like dirty pond or something. The other
So
other
there was a
factors.
similar history of other bacterial infection like oral infection or ear infection. This type of history was present in all the three patients.
Secondary infection was induced somehow.
Yes, sir. So they were also COVID positive. So the primary infection may be viral conjunctivitis, but it got super infected with the bacterial infection that they were carrying might be because of touching.
So I think, sir, I think in these cases where we are seeing tissue destruction necrosis is happening, is it not good to start with a soft steroid along with the under bacterial cover to prevent necrosis rather than
Use moxifloxacin.
45 drugs.
Which 41?
Vancomycin, I think.
For the COVID, so the COVID is I think virus. So why did you use an antibiotic?
Yes, so it was found to be culture report shows growth of staphylococcus positive.
So that is secondary infection to something else. Okay,
Yes.
okay, you want. So his point is very right. Even this point, this is very controversial. Whether in the infections, particularly corneal infection or conjunctival infection, we can use the steroid with antibiotics. But somehow now consensus is going. There was some survey in private group, so people are using steroid. If we say EKC right now, I have used in all cases antibiotic with the steroid just because of cheaper of that, but we plain antibiotic, and I didn't see this time any SPK and all that. So sometimes
sometimes controlling inflammation is more important because tissue destruction will lead to the peripheral thinning and perforation.
Yes, sir.
It was lucky that the eye could be salvaged,
Yes,
but
sir.
sometimes it can be devastating. So better to start when you are going aggressive. When you are going aggressive, work complete aggressive rather than like stepwise.
Dr. Nikhil, comments.
Can you go back to the previous cases? First case.
Presentation का on करो.
Just I want to ask whether you have any reference, any COVID has caused this keratolysis or such, devastating keratolysis. Any reference?
Yes, sir. There are studies in which they have shown that in COVID-infected patients, the levels of interleukin 6 they increases and they cause corneal apoptosis. So there's.
But when you look at this picture, clearly, this picture is never seen in like viral conjunctivitis. Such type of pictures is always bacterial. if you could see there is a thinning of peripheral thinning over there, there are infiltrates over there.
Yes,
So
sir.
such type of picture is never seen in viral conjunctivitis, I think. And secondly, the question is whether you started fortified vancomycin on the basis of gram staining or on the basis of culture.
So on the basis of culture
So culture
report.
might have taken you 10 to 40
Yes,
days.
sir, 7 days after.
So that was a mistake what you did, I think, because
So you started plain antibiotics
while
at presentation.
you have to start fortified antibiotics. You are seeing the peripheral thinning, you are seeing this infiltrates. So if you should have concentrated sapphire cobra, which we normally use, that would have also responded somehow. Yeah. So I think this stage which have gone further could have been salvaged. Second, can you switch to next case? Yeah. So what you did for these? Did you do something or you just left?
No, so they just healed completely. We didn't start
More
anything. We
of
just
sclera
gave
melting
antibiotics.
and all that. No?
Thank you. So we'll move.
One thing, just a small suggestion. Sometimes we go for the so many big things. So my funda or like my following is this. You always go for the small simple things. If culture takes 7 to 10 days, the one very small and within few hours you can know whether it's positive or negative or bacilli or sometimes. So this is a gram staining. So we are just neglecting all old small things. So before culture, ask them to do the gram staining also, and gram staining is very helpful to just
So
starting.
we sent all the reports to Grand Staining KH Mountain for
So the
culture.
gram staining, what does
Yeah,
come
that,
in?
that report is not.
Acha, okay, fine.
So probably gram staining would have been negative because he was already on moxifloxacin.
Moxifloxacin.
So till the culture came, what was the patient on?
So the patient was on lubricating eye drops and moxifloxacin.
So as Dr. Nikhil said, that was a mistake probably. I already looked that it was kind of going to perforate, so only moxifloxacin at that time. And yes, I also agree that seeing this picture for the first time, it would be very difficult to suspect that it is a secondary bacterial cause due to a primary viral, that is COVID. So what made you think in that direction when you saw this patient for the first time? Was it like and
So patient has history of COVID positivity 1 month back also. Then he developed again. So
but you had said that there was no history of any fever.
So 1 2 months. Yes, there was when he presented to our OPD with these symptoms. At that time, there was no history of fever.
Okay, but he had 1 month.
One thing more, we are discussing this for the just giving the our understanding better. We are all contributing in this. One thing more, this picture was like a keratoconjunctivitis basically, looking like in this way, and sometime it may be. What was the patient's age?
So 13 years.
Huh?
13 years.
1 3.
1 3.
Oh, okay. Any autoimmune like history of autoimmune disease,
No.
juvenile rheumatic fever, arthritis, and all that? Child was active.
Yes.
Was he male or female?
Male patient.
Acha, so in uveitis is common in males or females? Autoimmune is common in males or females?
Male.
Males, pakka. Okay. No.
Okay, so I'll now invite now next speaker, Dr. Nikhil Agarwal, to speak up on SLET, a simple and effective technique.
Discussing on the topic on. So I would be discussing on the limbal stem cells. So we all know limbal stem cells are essential for maintaining the integrity and transparency of the cornea and the straddle between the conjunctiva and the cornea, and they resides in helices of bones. So maximum number of limbal stem cells are found in fovea and inferior limbus. And theory, as we all know, it's a XYZ hypothesis in which one cell retain in the limbus and other cell proliferate to the center of the cornea. So basically, it functions to prevent the migration of the conjunctival epithelial cells and maintain avascularity and transparency. So there are few of the causes which we can discuss, like what are the causes for liver stem cell deficiency. It could be genetic causes like aniridia, autosomal dominant keratitis. It can be acquired like dry eye deficiency or like long extended dry eye, contact lens induced, ocular burns, radiation burns. And there can be also immunological disorders like pemphigoids, rosacea, graft versus host disease. So in the next slide, so this is how the normal ocular surface looks like. In the A, do we have pointer? Pointer. So in the A slide, what we can see is the normal ocular surface in which you can see the healthy limbal stem cells. Similarly, so similarly in the picture B, what you can see over here are the penises of box where the limbal stem cell resides. So this is a third photograph which show how the OCT of a normal cornea looks like and how the stroma is like very translucent type, not very hazy. And this is the OCT angio which shows that the vessels around the limbus form a hairpin-like structure which supports the microenvironment of the limbal stem cells. But what happens when they are stressed? So this is how you can see there is a hypertrophy of the limbus which shows the limbus is stressed or inflamed. Similarly, here you can see there is some like loss of the limbal stem cells over here. And this slide shows there is a partial limbal stem cell deficiency. This also shows a limbal stem cell deficiency along with symbliform formation. And this is how the more advanced stage of limbal stem cells look. There is 3 limbal stem cell deficiency along with pannus formation, along with vascularization, and one more step ahead is the granuloma formation. But if we are not treating over here also, then what we are getting over here, bone dry surface, complete keratinization, complete loss of limbal stem cells, which are only treatable by keratoprosthesis. So what we should do when we are looking forward for limbal stem cell deficiency? So this is a algorithm developed by the Vajrani et al. And Dr. Samwan, we all know them. So here, if it is a unilateral stem cell deficiency and it is only involving 2 or 3 cloacas, 4 cloaca limbus, then we only can do the conjunctival autograph. But if it is associated with more than 6 cloaca, 360-degree limbal stem cell deficiency, then what we have to do? We have to go ahead with the SLED. But if it associated with symbiotron, then we have to do conjunctival autograft also. But what about these eyes, bilateral limbal stem cell deficiency, or only one eye is available? Then what you can do? You can do the alloslate. Alloslate is taking the tissue from the living donor or the cadaveric donor. But if these doesn't work, then we can go ahead with the modified osteokeratoprosthesis or type 2 keratoprosthesis. So if we are going to select the cases for the SLED, what case we select? This is in the first A group. You can see there are some cases which shows there is a wet surface is wet, and you can also see there is a limbal stem cell deficiency. You can see there is a vascularization, there is a pannus formation. So these are all the cases which we can go ahead with the SLED. Similarly, what you can see in these cases, you can see there is some symbliform formation. Here you can see symbliform formation. Here you can see symbliform. Here you can see more symbliform. But here also you can go ahead with SLED and AMG. Conjunctival autograph. But what about these cases? You can see here the limbal involvement is less than 6 cloacas. In this case also, so here we can see the limbal stem cell deficiency of around 4 cloacas. So here we don't need to do limbal stems transfer. We can do just resect this pannus and do the conjunctival autography. But what about these cases? These are the bone dry surfaces like a complete keratinization. Here we don't do anything. Here we do only keratoprosthesis. So if you give 1 minute, you can share a video. Yeah. So this is how we do the simple limbal stem cell transfer. You can see how the eyes looks like. So we do the 360-degree conjunctival peritomy. Why I consider it a simple surgery? Because it doesn't need any hi-fi machines. Because we don't need any like very high technique. But we need to have a good plane. While dissecting the eye, when I did peritomy and I find a good plane. So you can see here. Once we are dissecting the pannus, cornea itself is very clear. But here also we are like do anterior reticulotomy around 150 micron we did. So now you can see the clarity of the cornea from the. Then what we did? We did amniotic membrane transplant on this. Then we took a limbal biopsy or donor from donor eye. Donor eye is the eye of the same patient, but from the other eye. We have to go 1 mm inside the limbus so that we can get some limbal stem cell. You can see the color is little bit different from the conjunctiva, it's pigmented. So these are limbal stem cells we place in the mid periphery with the help of a glue. So we place the glue over here. And this conjunctiva which we have like we have cut, we will stitch it and place the BCL and surgery is finished. So a simple surgery, but results are very good. You could see here, this was the first case I did for chemical injury slide, which I did with Simplifron release with Gelma formation. So it was the first case, and also you could see how beautifully the penis was dissected and how beautifully, and this was result after 3 months. And now the patient is almost 6 by 12, last follow is 6 by 12, and patient is doing really good. It has been almost 2 years follow-up. So this is the partial limbal stem cell deficiency. What we have learned, I did a mistake in this case. It should be have only conjunctival autograft, but we did slat in this, but the results were very good. Similarly, this was a girl which we did like 3 months back. So she was like chemical injury to the injury for last 10 to 7-8 years. So she was like this, and there was also Simplifron formation over there, upper superiorly. So what we did over here, we did a simple limbal epithelial transfer with conjunctival autograft in the above part. So you can see this is after 3. This is the recent follow-up which we last 7 days ago. So these are some of my good person who always help me when I am like in trouble. So these are Sanvan, Sain, Basu, Rani and Dr. Purvasan. Thank you very much.
Sir, for the sake of saving the time, we'll take the discussion at the end.
Yeah.
Sure. Thank you, Dr. Nikhil. Now I welcome Dr. Savita Meena to present on corneal tear repair and foreign body removal. Next speaker, Dr. Nidhi ma'am, will you be using laptop or presentation? Laptop, so you can just.
Good morning, I am Dr. Savita Meena. I am presenting foreign body removal from anterior chamber. So, we got a case of a 24-year-old male presented with trauma in left eye, which was operated outside. It was a corneal tear, which he suffered the trauma while working in the field. It was repaired outside, but on examination, the chamber was leaky, it was shallow, the corneal contour was poor, and iris tissue was incarcerated in the wood. And the CT was also done outside, and it showed no foreign body. We decided to operate the patient because it was a good prognosis case. So resuturing was done. After resuturing, we got a good corneal contour, iris tissue incarceration was released, and got a good post-op vision. Patient was discharged and advised to follow up. He was advised normal antibiotic, moxifloxacin, Natamat, atropine, and painkiller along with Predford. This is post-op day 1. Cornea was a bit hazy and there was reaction in AC. Patient was asked to follow up after 1 week. But during the examination, or during the surgery and even after the examination, we missed something. On his first post-op visit, I noticed a foreign body in anterior chamber. It was embedded in the iris. It was similar to the color of iris, so it was camouflaging with the iris. As the anterior chamber is clear, the reaction is reduced and the cornea is clear, we can appreciate the foreign body which was missed during slit lamp examination during the surgery. But we cannot leave foreign body as such, so we decided to operate the patient for foreign body removal. We deferred MRI because we were not sure that it's 100% not a metallic foreign body, it could be a metallic foreign body, so we deferred MRI, and based on CT finding, we went ahead with the surgery, but based on CT finding, it is probably a wooden foreign body because it was not showing in CT. During the surgery and even after the surgery, we had the risk of hyphema, endophthalmitis, cataract and iridodialysis. The foreign body was on 6 o'clock. So we made a main port opposite to the side, to the foreign body, and we filled the anterior chamber with viscoelastic cohesive, and also injected some cohesive viscoelastic below the foreign body in order to avoid damage to anterior capsule. Then with the help of microfurcin, the foreign body was removed, and from what we can see, it's almost double the size of what was initially visible on slit lamp examination. During the removal of foreign body, I was facing bit of difficulty, and then I decided to enlarge the side port, but realized that the side port is already of sufficient size. So with help of little maneuvering, I was able to remove the foreign body. Okay, then I just did AC wash and formed the chamber with air bubble. The size of foreign body was almost 3 mm. After the surgery, we faced lens opacification, decrease in post-op vision, complaint of pain and reaction in AC, and hazy media. So we suspected either a simple breach in anterior capsule leading to cataract or lens abscess, which was a dreaded complication. But in B-scan, we found an intact posterior capsule. So, and there was no reaction in posterior segment. So after retina expert opinion and USG finding, it was
Doctor, a little bit, we are getting short of time. So can you just hurry up?
Then we currently we are planning for traumatic cataract lens aspiration and IL implant for a fourth surgery. Thank you.
Thank you. Okay, thank you so much. I'll just move.
To make one comment. When you remove the foreign body, did you inject any intracameral antibiotic at that time?
Yes, sir. We injected intracameral moxifloxacin.
So, because that was not shown, but that is an important step that needs to be there, because the patient went into end off. So at least if it was done, then you were little safe.
Yes, sir. Yeah. And so we started oral antifungal also before the procedure.
Thank you, Dr. Savita. I would like to now move on to next speaker, Dr. Nidhi. She'll be speaking upon ROP, examination to laser.
A very good morning to all. So okay. So retinopathy of propensity, we all know what it is change. ROP, so it's a retinal vascular disease of premature infants leading to preventable childhood blindness. We all know the risk factors: low birth weight, prematurity, prolonged oxygen therapy. My presentation is ROP, introduction. So what is ROP? We all know it's a retinal vascular disease of premature infants leading to preventable childhood blindness. Today it constitutes 20%, meaning incidence in India is 20 to 50% of babies born less than 1500 gram. So the risk factors: low birth weight, prematurity, prolonged oxygen therapy, multiple transfusions, gestation, sepsis, RD. And it is important whom to screen. All of those kids who are less than 2 kgs, gestation is less than 34 weeks with an unstable clinical course and at high risk. So documentation is very important when we do ROP screening. So we have to note all the accurate details of zone, stage, clock hours, and presence of pre and pre plus or plus, because this will help in follow-ups and disease status of baby being whether we have to refer or even in medical legal aspects. Now, how to screen? So before when the child comes to OPD, you have to tell them it's not a normal tropicamide, it is diluted 50-50. So like what we have in our OPD is 1% and 5%. So it is diluted and it's 0.5 and 2.5% is used, and then we have to use an IUN 2080. So when to screen? So the less than 28 weeks of kids should be screened within first month of their born, and if they are very serious and all, we have to visit to NICU to examine them. Now, when should you stop screening? When there is a complete vascularization, when vascularization is there in zone 1, 2, and when it's over 45 weeks. So the staging is in stage 1, 2, 3, 4. It's depending on the presence of ridge, demarcation lines, and zones. I will not be dealing into it here because it will be out of scope of presentation. But here in AIMS, what was our experience? We had totally examined some outborn 68 and inborn 188 kids in 1 year, and we had found only overall 62% kids had ROP. So 256 kids were examined last year, and in that 62 ROP, zone 1 was in 5, 34 were zone 2, and 3 were zone 3. Now the various stages. Stage 2 was the maximum with zone 2, and rest of them were there but not that significant. So we had total ROPs out of 62, 24% had AROP, when 76 were not that serious. So the AROP kids need urgent. The AROP is emergency, because if they are not treated at the same time, they might go to devastating condition that we cannot they will lose their vision permanently. So we had to urgently give them anti-VEGF and followed by lasers. Well, other kids were lasered, so there were total 24. And risk factors were preterm weight, low birth weight, oxygen. So we have found it. One important factor, I think, as an ophthalmologist, we should all tell to a neonatologist that oxygen percentage should not be high more than 30%. They in PICU, especially in periphery, they give 100% and maybe 60-80%. So this should be tell them. So zone 2 vascularization with marked vascular loop and tortuosity, and this is the case pre-laser and this is the post-laser how it looks. And anti-VEGF, it is very good, but the side effect with anti-VEGF is that it is systemically unstable. It can lead to cardiac problems and all. So we avoid going for this. So to conclude, it's a required combined defense of parents, ophthalmologists, neonatologists, and good deco practices and timely screening. Counseling of parents is essential depending on severity. And these are the long-term sequelae, like there can be traction, keratogenous, RDs, and retinoschisis, avascular retina, macular abnormalities, retinal vascular changes, abnormal dichotomal retinal vessel branching, and vitreous hemorrhage glaucoma. So this is a video. How do we examine? It's very important while we examine, the baby should be in NICU, especially when we are doing laser. The hospital ambient setting should be good. The staff which is here, she should also have the goggle while doing laser, because it's very important, and it should be dimly lit room, and baby should be comfortable, warm in an incubator, and generally we have to do examine. It's a tedious process. It takes almost 4 to 5 hours for one kid.
Ma'am, requesting.
Yes.
Okay, ma'am. Sure. Thank you.
Thank you.
Yeah, I'll now move to the next speaker, Dr. Zain Khatib, and he'll be presenting an ASCRS video award tips for young ophthalmologists, so that you can make a prize-winning video.
Thank you, Roscon and Dr. Sonal, Dr. Vishal for inviting me to be part of this conference. So I just want to know how many had ophthalmology as a first choice when you started residency? Nilesh, ophthalmology first choice. Okay. So this is what most people think when they get into ophthalmology. Most of them, most people don't. They get in by accident, and they feel that it is a branch which is separate from the rest of medicine. It's chilled out. There are no emergencies, and it involves theoretical stuff that is different from actually what you've been learning in the last 6-7 years. Once you spend 2-3 years, you realize that actually it's not very different. It's very similar. It's definitely chilled out, but you are a surgeon, and there's a lot of medicine involved, as we've seen from the previous presentations. It's not really that different. And we do surgeries using industry-driven products, high-tech equipment, microscopes. So as a result of that, we get to attend a lot of conferences because we are an industry-driven branch, and we get time because there are not that many emergencies. And because of our surgical recordings and because of the conferences, we get an opportunity to present surgical videos right from the start. So I would say, ophthalmology, in fact, compared to other fields of medicine, is a branch where surgical videos are given a lot of importance. This is something that you must realize, in your residency itself. So it's been exactly 10 years since I joined ophthalmology. My residency started in 2013 October. And I was exposed to my first big conference in 2014. We were a branch, we were a batch of 10, and 8 were girls, 2 were boys. So all the 8 girls decided to go for a state conference, and they made me and my colleague wait back, so what I told my HOD that after 2 weeks there's APACRS conference in Jaipur, which I want to go for. So he said, you go for that. And when I attended this APACRS in 2014, I was amazed at the surgical videos that are presented there, and the film festival and all. It is something that really inspired me to make surgical videos. And then over the course of next 10 years, I attended and presented at different conferences, and it all culminated to me getting an award this year at the ASCRS. I'll just show you, how the level of grandeur. I mean, this is considered the pinnacle of awards for us in terms of the film festival.
Over 150 submitted films from 30 countries. Our expert judging panel has been carefully and virtually evaluating the film entries. Today, the judges will present a coveted award to a winner and runner-up in each of 10 categories. Now, let's find out who will win this year at the 41st Annual ASCRS Film Festival Awards. Please welcome to the stage, Dr. Shahar Tub.
Just a glimpse to show you, how this is conducted.
You guys, all of you. Good evening, everyone.
The runner-up is Zain Khatib, planning of
You don't know for sure that you're going to
using a
win. You
new
don't know that
vector
you're going to win an
mathematics
award.
based
Unlike
software
other
from
conferences,
India.
where they tell you, they send you an email that you should attend. Here, you're totally, it's a very great moment, and all the judges are sitting on the stage, and you have to go meet all of them personally, and then you're given this award. And if I could make an award-winning video for ASCRS, anyone can do it, because I am not backed by a big institute, or I don't have like an in-house video team. It's just that you need to follow certain basic principles to make good conference videos. Okay, so the first thing I would say is you need to have a microscope with a recording system, which most institutes do have, but if you are on your own, you should make sure that you have a good recording system. The second thing which I would like to say is focus and clarity are two things that must be there every time you are operating. So you should make sure that not only you can see well, but the person outside can see well, and the camera also can see well. So this goes a very long way, and if you feel you are not focused, pause, focus, and then continue. You need to have a device which can record, videos with high data. You can have an SSD, or if you have it on your phone, you can probably have a phone with big data. You need to know basic video editing, and you need to have a good software to edit videos. And finally, you need to have an innovative mind to know how you can present videos to win awards and in different conferences. So the general film festival categories are based on segments, or you can present challenging surgical videos, or you can present some innovation that you have done. But for young people, and what I have learned is the best place to submit is in a resident in training category or a new producer. Here you have chances to win awards the maximum. So in 2018, I won my first video award at the European Society, and this was a horrible video. It was as a fellow, I made a mess of the surgery. I tried searching for it, but I couldn't find this video. So it was a case where I made a bad wound, the iris prolapsed, and then my boss took over, completed it, and did the phaco from the other side. But just that I presented it in such a way that it gave a lot of teaching pearls to the audience, so that's why it won in resident in training category. Doesn't always have to be a good video, you don't have to be a good surgeon, you just have to know how to make a good video. And suppose you don't win awards in the conferences, you can still present in sessions. So in ESCRS for the next 3 years consecutively, I sent videos in the young ophthalmologist category. And this is not competitive, but you get to present in front of international peers, and they critically analyze your video as well. You also have separate sessions like IRSI, when the going gets tough, the tough get going, where I presented a video yesterday, and lot of small 2-minute, 3-minute video opportunities keep coming in different conferences. So just to conclude, you should record, analyze and study your videos well. You should learn to edit all your interesting videos. You should study your complications and try to find solutions and not repeat those mistakes, and learn how to present those complications as videos. And you should send videos to all possible conferences. No ego, just send it even if it's bad. But most importantly, if you want to win, you should know how to submit the right content to the right place. So this was the topic of my video which won at ASCRS. It was a LASIK software that I have made, and I submitted it to a lot of places before. It did not win, forget winning, it did not get any recognition anywhere, but I knew ASCRS, which gives more importance to refractive surgery, would probably understand it better, and then I won the award over there. So this was just basically a motivational talk to how probably you can learn to send your videos to the right places. And I thank Yossi for giving me this opportunity. This is our great team of Yossi. Thank you.
Thank you, Dr. Sen. Dr. Nilesh, any comments or anything?
I have been seeing sir's videos, and I think the most critical point what he told is it is not what the video was about. Was it a good surgery or a bad surgery? Are you putting a message across? Even if it is a bad surgery, how to salvage that, or how to avoid that? I think Sudhir sir has been on YouTube for a long time, and his videos has a larger viewership.
My idea is always different. I never work for the award. Award the secondary thing that come usually. So this is by my development, my videos. I am a student. I am a teacher. I saw repeatedly how we can improve. Otherwise, so I always, when you are going for investment, you go for good microscope with camera. And now we are having so much of microscope under 20. Go for phaco machine basic. Don't go for centurion. No thing. I'm not against the high technique. Later on, it's okay for the many things. But it's a good habit to record all of your activities. Is that idea?
So yes, so in my residency I didn't have a recording system, but we had a side eyepiece. So I used the phone adapter and I had to record from the phone. So just seeing your own videos, it makes you learn so much.
Sometimes you don't know what went wrong, and if you don't have a recording system, then you just contemplate that okay, this might have happened. But when you see the mistake, then from next case you are always aware of that, and you try not to do that.
I can tell you just 30 seconds. Maybe good for the young ophthalmologists. My two innovations come from my recordings. One is the reverse phaco chop I usually do, and one is the internal phaco fracture. It comes from that. When I was showing just in the lazy time, I always on computer, so I used to see my surgeries in the that time. So that time, ये कैसे हो गया? So we can plan it. Next में उसमें भी हो गया. So then, when I have not recorded, then I won't be able to do this. So good habit and good talk for the juniors.
Thank you, Dr. Chen. Please. Last, we'll move on to the topic. Mr. Bhaumik Shah, he'll be presenting on optical dispensing, and I request. Then after this, we'll have a group photograph with the certificates, and then we'll be moving to the oration, which is I think have started over there.
Good morning, everyone. It's an honor to be here this morning, and I'm extremely grateful to Roscom for giving me this opportunity to share my insights on achieving patient satisfaction through a delightful dispensing of opticals in an eye hospital. So here, let's first meet Aisha, who represents the provial patient that you all have today in Tier 2, Tier 3 and Tier 1 cities of the country. So Aisha is a typical female, 55 years old, a parent of 2, very well informed, aware, tech savvy, and she also holds key influence on the lifestyle factors and the purchase decisions that are made for her family. She is technologically very savvy, as are most patients even in the periphery that we encounter today. And she prioritizes lifestyle choices for herself and her family, along with continuous health goals, where her preferences get slotted into 4 quadrants. The first being her need for functional precision eyewear. Second, the accessibility of that availability in terms of the right optical assistance. And third, the trust that she would expect from the optician in terms of dispensing the product that she genuinely needs, along with the style and comfort that would please her as a consumer. So this is where things have been evolving with the optical field as much as with ophthalmology itself. And before I sat down to express my views and my thoughts on how is it that we can improve the levels of dispensing of eyewear in your hospitals, I would like to focus upon the why. Why is it pertinent that optical dispensing should be an integral aspect of general ophthalmology practice? And this is corroborated further by a very insightful survey that we commissioned across 30,000 consumers in 10 cities of different socioeconomic profiles. A staggering 86% people say that they prefer ordering spectacles where they get their eyes checked. 50% respondents say that they would prefer to have their eyes checked at a place with a proper clinical setup. 100% of the respondents felt that there was no connection between the eye checkup that was done and the products that were dispensed. Another 100% felt that their optician did not understand their vision and power specific issues, and 95% of the respondents felt that it was a hassle for them to go back to the hospitals with complaints about their vision despite of having their new spectacles made. So this is where it becomes very pertinent to have this all important aspect that eventually determines the efforts put in by your team towards establishing the vision correction of your patients to have the fruitful outcome, at least in complementing the efforts that you and your team have taken towards establishing it. So we believe that there is one entrance to every eye hospital. However, there are 5 exit points wherein the interface happens with OPD consulting and procedural matters and surgical interventions, pharmacy, and eventually the optical store. So while your pharmacy partners and your IOL partners do keep you aware and support you in terms of upgrading yourselves with the new advancements in the field of pharmacy and implants, but that doesn't always happen in the case of your optical store, right? Because there's hardly any initiative that happens with regard to making you aware about the new advancements in the field of optical dispensing. So why is it pertinent? Because we have observed that for a successful ophthalmology practice, opticals carry the propensity to contribute to as high as 30% of a hospital's revenue apart from ensuring that your patients are dispensed with products that qualitatively meet your own criteria of prescription and treatment. And this is a huge problem in India today. So why is it that a hospital should have an in-house dispensing in the first place for opticals? The survey that we did corroborated further that every 3 out of 5 patients in India prefer to make their spectacles from a place which is advised by their prescribing doctor. As high as 70% patients want their prescribing doctors to advise to them in terms of the specific types of lenses that they would need to have the right kind of vision that the treatment implies. Typically, a patient spends 9% of the amount that they spend on cataract surgery towards eye hospitals. It is also very pertinent that 2 out of 4 patients are dispensed wrong spectacles when they go out to an optician in the market. And the patient doesn't realize that the problem of vision that still remains at large is because of the spectacles that have been poorly and wrongly dispensed, and not really because of anything to do with the checkup that has been done. And the patient keeps visiting hospital with a complaint of vision that largely remains unanswered.
Sir, just for the time's sake, sir, I would like to sum up as much as possible, sir.
I'll just take a minute.
Yeah, sure. Thank you so much, sir.
Sure. So basically, these are the 6 points that we would recommend are practiced by your optician, okay, towards achieving the optimum delight through patient satisfaction. I'm not saying that this is the proverbial holy grail that's going to take care of all the issues that remain with regard to optical dispensing, but yes, these points would most definitely help you overcome most of the obstacles that are felt while dispensing eyewear to your patients and the issues that may be arising at your hospitals. The first is patient engagement, where the engagement needs to happen right at the time when the patient is there at the hospital awaiting his turn for the checkup. Second is awareness of the patient. We have immensely advanced technological tools to counsel on products which make it very easy for patient to understand about what kind of tools are, what kind of products and what kind of technologies are available today. We have technologies today that also dispense products very accurately without having excessive reliance on people. We also have today guidelines on the right kind of product assortment, which is customized for your own patients depending on their profile. And when the counseling happens in a manner that the patient understands it very effectively, you obviously also have a conviction on the price that the patient bills, and we have been witnessing it all across. And finally, the people power, I mean the people who dispense these products. These people act as conduit between your happy patients and the dispensing that happens, and these people need continuous training and monitoring, which is what happens when you have a specialized setup that is dedicated towards this work being done. It's not possible for me to take you all very elaborately through each of these innovations that have happened, which have been practiced by us. So yeah, if any one of you has any academic interest, please do visit us. We are just right around here, and we'll be happy to demonstrate these innovations that we follow. Thank you very much for your time.
Thank you, sir. A small question I would like to know. So as you mentioned, there are multiple exit points. Because of that, many times the patient's satisfaction goes a little bit down till the time he reaches the optical. Because of many times they have 1.5 hours or 2 hours to waiting time. So do you suggest that many times when the patient enters in the reception or the area, do you think that sorting out such patients, that those who have come only for the optical services should be taken through a short phase, like maybe directly a refraction and directly to the optician, and only a small part of doctor checkup, so that they can be processed fast and the satisfaction can improve?
Absolutely. In fact, that is exactly what I meant when I said patient engagement. Normally, what happens is that in the 1.5 hour that a patient spends at an eye hospital towards the entire journey of the checkup, when the final prescription is given, the patient is not really aligned to visit the optical and spend any more time, because the patient feels that there are enough and more opticians outside where they can go at their convenience later on. Which is where, if the optician engages with the patients while they are waiting for the turn for a checkup as a seamless activity, and where opticals is made to be an integral part of the patient journey of the hospital itself, then you are building up the interest and curiosity of the patients beforehand, even before they undergo a checkup, even before they are advised spectacles. And I think this is how the whole journey triggers. Yeah, sure, thank you.
So I'll again invite all the speakers so that we can have a group photograph and the certificate distributions.
लाइट मिले थोड़ा लाइट में बस बस
Thank you, President, for the presence. Dr. Nilesh, please. I invite Dr. Nikhil. I invite Dr. Nidhi.
सर
I invite Mr. Bhaumik Shah. Dr. Savita Menon.
अभी का है कल सुबह तक यहाँ से
गब्बर सिंह चलो उधर
In the session of financial management for all of us, ROS started a new program and we will deal all the basics and then interactive session, question and answers by all. We will try to give best possible answers to you. With me, CA Mr. Mukesh Bansal is there. He is on panel of SEBI financial advisor, Dr. R.K. Verma, Dr. Nilesh. We will try to cover each and every aspect of financial management as well as personal basics.
So
So first presentations of this session will be basics. And as far as investment and other things, tax consult, they will dealt with CA. Mansur Saab. So I'll take only basics of personal finance. Financial aspirations of young entrepreneur will be taken by Dr. Nilesh. Motive behind this session is to gain some insight about personal finance, to make you aware about all common financial mistakes we usually do, and to avoid getting misguided by financial advisors and agents. But it is seen that we are soft targets for all the financial advisors. We just want to educate yourself to be aware of all that. Certain things you must know about balance sheet, cash flow, although every eye surgeon is filing his returns, so he must be aware, but you can be see inflow and outflow of cash, total receipts, household and clinical expenses like that. These investments parts will be taken later. But in short, what I stressed, every investment should be goal oriented. How far is your goal? 2 years, 5 years, 7 years. And these goals may be personal as far as new house as well as retirement is concerned. For family, children's education and marriage, professional upgradation of your clinic, instruments, infrastructures, and luxurious goals are world tour, etc. In beginning of the practice will be taken by Dr. Nilesh, and these are some basics of finance management. Emergency fund, taxation, insurance and investment. Previously it was said that about 6 months of your monthly expenses should be kept in liquids, either in saving account, cash in hand or liquid mutual funds. But after COVID, it was suggested now 6 to 12 months of your monthly expenses should be kept in emergency funds. And do not disturb these funds for routine expenses. As far as investment is concerned, CSR will take care of it, but I'll just mention a formula of GRED, grade, gold, real estate, equity and debt. These are the investments. Debt investments, cyber frauds nowadays on the rise, and these are some online numbers. As soon as you came to know that some cyber fraud is likely to happen, or by mistake you have given some details, please report immediately. I'll talk about insurance. Number of insurance from number of companies are available. Please do not go for that. Only 3 insurance I am mentioning: term insurance, health insurance and general insurance. LIC and ULIP, big no from our side, because LIC means loss is compulsory. Term insurance we can take from different companies, and our own AIUS having family benefit scheme and IMA having national social security scheme. As far as health insurance is concerned, basic mediclaim, top-up mediclaim and super top-up plan. These are little different, but I suggest basic 0 to 5 lakhs of basic mediclaim and 5 to 50 or 1 crore super top-up plans. Regarding loans, CA Mukesh Bansal will tell you. And taxation, income tax slabs, consultancy services and GST. Here I'd like to mention very brief, GST means goods and services tax. Although our professional services are exempted from GST, but if any other commercial activity is there, suppose a consultant eye surgeon having a commercial building and receiving rent from that, you are liable to GST, because the limit is only 20 lakhs, and if that rent may be of 1 lakh, 2 lakh, added in your income, that certainly will go beyond 20. So that is also a problem. We have two kind of services now. Initially we are having only consultation services to our patients, but now some companies are also taking consultancy services from the eye surgeons. That consultancy service to the companies, not to the patients, to the companies, if you got any remuneration, that is under GST. So be watchful for that also. Something about bank accounts, number of facilities, number of type of accounts are available, saving as well as current accounts. In saving and current account, holdings is different. Single holding, joint holding. Joint holding means 2 or 3 persons having joint account, but that cannot be operated without consent of both. And if either or survivor, anyone or survivor, anyone can operate that account. That depends upon your relations. Preferably one should have either or survivor or anyone or survivor. GST I have already mentioned, and these are the some summaries. Do have emergency fund, tax planning, term insurance, general insurance, direct mutual funds, PPF and NPS. And please do not go for LIC, ULIP, regular mutual funds, trading in shares, tax evasions. I'd like to mention that this financial education is also having grade. If you are in nursery grade, attempt questions of nursery. If you are in LKG, try to. Depend upon you. To start with, you can have PPF, NPS, index mutual funds, and rest will be taken care by CA Shri Mukesh Ji. Thank you. Dr. Nilesh, next presentation.
In the meantime, if you have any question, you can ask. Our CA is there, expert.
Hello. Yeah, sir. Thank you, sir. Thank you, Ravi, sir, for providing me an opportunity, and thank you, Dr. Vishal, sir, and ROS for inviting me to this finance session. I am a young entrepreneur. I am second generation ophthalmologist. I've taken my father, and now we are trying to develop that clinic into a hospital. So I'm going to talk about financial aspiration of a young entrepreneur. So these are my financial disclosures. So why this topic? Once we enter the hospital, we all think that we should feel like Superman. Every patient is just waiting for us, trying to just get in contact with us, and we are rolling in money. And then whenever we want, we just close it and go for a vacation and be relaxed. But it is not. It is a rocky sea. And we are alone, standing on a hill, and there is no way to get out. That's what we feel. And this is a journey from that to being what we want to achieve, that is the aspiration. So it is costing you around 20,000 rupees, will be costing you around 32 lakh rupees. But if you buy that machine on EMI, for that 10 lakh you are going to pay 20 lakh in 20 years. But when you start saving and start doing SIP and save for that machine, you will be spending on only 13 lakhs. So 32 lakh ke liye you are only paying 13 lakh, 1/3 of the amount that you need to spend. So that is the beauty of SIP. And when you are planning to upgrade in 5 years, start doing SIP from today for that, rather than waiting and taking a loan and then start paying EMI. So with that, for financial and tax planning, let the master show how it is done. Thank you so much.
Thank you, Dr. Nilesh. Now I invite CA Mukesh Bansal for giving, and his talk will be of 20 minutes. His talk will be of 20 minutes.
Good morning. Good morning. I'm C.S. Rupesh Mishra. By profession, a company secretary and a chartered accountant. I headed this chapter of Institute of Company Secretaries for long 14 years. And now with the advent of SEBI, I am with the SEBI for long 15 years now and spearheading this financial literacy among various groups of the professionals and education institutions. We are into, my expertise is mutual fund, my expertise is portfolio management services and alternate investment funds. So do not save what is left after spending, but spend what is left after saving. My fundamental is very clear. Normally हमें जो सिखाया गया है वो सिखाया गया कि income minus expenses is equal to savings, and which is not true in this rising scenario of expenses and lowering scenario of income. तो जो हमें डेफिनेशन को चेंज करनी पड़ेगी वो डेफिनेशन हमें दूसरी समझनी पड़ेगी और थोड़ा सा डायनेमिक्स चेंज करना पड़ेगा. Income minus savings is equal to expenses. So whatever we earn, a small portion of that must be taken as a savings and rest of things will be for our expenditures. And usually for everybody I suggest 50, 30, 20, a formula which after a lot of investigation I have done. Whatever you earn, 50% for the family and for your business, 30% for your leisure and pleasure, but 20% set apart for investment, savings. What is wrong with the just saving? That is, inflation eats up our savings over a period of time. 6%, 6.5% की इन्फ्लेशन रेट है. हम लोग बहुत अच्छी तरीके से कहीं इन्वेस्टमेंट करना चाहते हैं तो बहुत सारे इन्वेस्टमेंट ऑप्शंस डॉक्टर साहब ने बताया. सबसे पहला है कि हमारा बड़ा पैशनेट होता है कि बैंक में पैसा पड़ा रहे. 2.25%, 2.5%, 3%. इनफैक्ट बाय कीपिंग द मनी इन द बैंक अकाउंट यू आर डेप्रिशिएटिंग द मनी. नेक्स्ट बड़ा प्यारा ऑप्शन होता है कि हम एफडी करा दें क्योंकि एफडी सबसे ज़्यादा सिक्योर. 4.5%, 5%, 6%. 6.5% से फिर भी डाउन है. हम सभी का जो एक पर्टिकुलर एज में आने के बाद पीपीएफ भी बड़ा अच्छा ऑप्शन होता है. करते हैं सब लोग, करना भी चाहिए. एक सिक्योर इन्वेस्टमेंट पहुँच जाते हैं हम लोग. पर फिर भी रेट ऑफ इंटरेस्ट से अगर हम लोग उसको कंपेयर करेंगे तो रेट ऑफ इन्फ्लेशन से वो चीज़ कम ही होगी. और इसका छोटा सा एग्जाम्पल दो तरीके से बता दूँ आपको कि 5% ईयरली इन्फ्लेशन कोई माने जो आज की तारीख में 6.5-7% है. तो अगर हमारी एक्सपेंसेस 30,000 रुपये पर मंथ है तो आने वाले 20 साल बाद यही एक्सपेंसेस हमें 8 लाख रुपये पे लेते हैं. तो क्या हमारी इनकम उतनी कमेंसुरेट बढ़ी है? क्या उतनी सेविंग्स हमने बढ़ाई है? क्या हमारे पास उस टाइम इतने डिस्पोजेबल फंड होंगे? दूसरे तरीके से समझिए, अगर आज हमने सेविंग्स की है 1 लाख रुपये की और 20 साल बाद अगर हम उसको पड़ा रहने देते हैं, इन्फ्लेशन से कट नहीं करते, तो शायद उसकी वैल्यू होगी 35,000. बिल्कुल परफेक्टली आपने देखा भी. इमरजेंसी फंड के बारे में डॉक्टर साहब ने बताया कि 4 से 6 महीने का इमरजेंसी फंड हमारे पास होना चाहिए. बहुत अच्छी तरीके से समझ लीजिए कि इमरजेंसी फंड बहुत जरूरी है क्योंकि कभी भी प्रैक्टिस से बाहर, कभी भी जॉब से बाहर, कभी भी कोई अनफॉर्चुनेट सर्कमस्टेंसेस लाइक कोविड आ गया तो ये इमरजेंसी फंड हमें बनाना पड़ेगा. पर इमरजेंसी फंड को भी अगर हम लोग डेप्लॉय कर रहे हैं किसी ऐसी जगह जहाँ लिक्विड फंड, शायद म्यूचुअल फंड है, 7 से 8 और 9% तक का आज इंटर बैंक स्टेट जो रेट ऑफ इंटरेस्ट से मिल जाता है पैसा, तो वो इमरजेंसी फंड को भी हम ले सकते हैं. और म्यूचुअल फंड में इमरजेंसी फंड का क्या है, आज आप 3 बजे से पहले डोनेशन डालिए, कल सुबह 9 बजे से पहले बैंक अकाउंट में आपका पैसा आएगा. और ऐसे भी फंड्स हैं जहाँ एटीएम की तरह काम ले सकते हैं. आप एक एप्लीकेशन पे जाके विड्रॉल करिए, 50,000 रुपये तक का अमाउंट जब तक आप एप्लीकेशन से बाहर नहीं आएंगे उससे पहले आपके बैंक अकाउंट में चला जाएगा. तो बहुत अच्छी तरीके से समझिए कि इन्फ्लेशन को हमारी सेविंग्स को खाने ना दें. और इसी के लिए हम लोग कर रहे हैं कुछ चीज़ें कि हमें सेविंग्स को तो जल्दी स्टार्ट करना होगा. बहुत बार हम लोग टालते हैं, जैसे सर ने बताया 20 से 30, 30 से 40, 40 से 50. जल्दी क्या है? सबसे बड़ी इशू दिमाग में आती है कि जल्दी क्या है. हम लोग क्यों स्टार्ट करना चाहें जल्दी? आज तो मस्ती का टाइम है, खासकर युवाओं के लिए आज मस्ती का टाइम है. ये ज़िंदगी ना मिलेगी दोबारा, बार बार हमें भरोसा रहता है कि हमें ज़िंदगी ना मिलेगी दोबारा. सारे मौज शौक हम पूरे कर लें, पर जितना जल्दी हम स्टार्ट कर लेंगे उतना ही जल्दी हमारे लिए बेटर है इन्फ्लेशन को बीट करने के लिए. एक अल्टरनेट ऑप्शन होना चाहिए. आपके पास जो पैसा है उसको वर्क करने दीजिए, काम करने दीजिए आपके लिए. जब आप सो रहे हो तभी आपका पैसा बढ़ना चाहिए. और सेविंग्स टू इन्वेस्टिंग, आप देखिए नोटबंदी के टाइम में घर की महिलाओं के पास बड़ा सारा पैसा निकला, तकिए के नीचे, साड़ियों के नीचे, अखबार के नीचे, आटे के डब्बे में। गलत था? क्या किसी ने चोरी की? क्या किसी ने कोई पैसा दबाया किसी का? नहीं, वो हार्ड सेविंग थी। लेकिन दो तरीके से गलत क्या हो गया, एक तो उस पैसे को कहीं जमा नहीं किया तो कोई रेट इंटरेस्ट नहीं मिला, और दूसरा रेट ऑफ इन्फ्लेशन से उस पैसे की वैल्यू कम हो गई। तो आपको समझना है कि अगर पैसा हमारे पास हमने सेव किया और कहीं इन्वेस्ट नहीं किया तो कोई फायदा नहीं। पावर ऑफ कंपाउंडिंग, इसको मैं आगे भी एक्सप्लेन करूंगा। पावर ऑफ कंपाउंडिंग को बहुत अच्छे से समझिए। सुप्रसिद्ध वैज्ञानिक अल्बर्ट आइंस्टाइन ने हमें बार बार कहा कि दुनिया में वित्त के क्षेत्र में 8वां आश्चर्य है पावर ऑफ कंपाउंडिंग। प्रिंसिपल इंटरेस्ट, प्रिंसिपल इंटरेस्ट, इंटरेस्ट, प्रिंसिपल इंटरेस्ट, 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 प्रिंसिपल इंटरेस्ट, इंटरेस्ट, इंटरेस्ट। क्या आप देखिए कितना फायदा होगा। आज दुनिया के सबसे अरबपति खरबपति इन्वेस्टर, जिसको हम कह सकते हैं वॉरेन बफेट, अपनी बिब्लियोग्राफी में, अपने जीवन में उन्होंने साफ साफ शब्दों में लिखा है कि मैंने अपनी जिंदगी में सबसे पहला इन्वेस्टमेंट 11 साल की उम्र में चालू किया एंड आई रिग्रेट आई वाज लेट। यहाँ 11 छोड़िए 21 साल तक तो हमें यह होश नहीं आता कि हमें इन्वेस्टमेंट का ABCD मालूम। 11 years he started his first investment. He does not own any industry anywhere. लेकिन इतने बड़े बड़े उसके पास शेयर्स हैं, इतने बड़े बड़े इन्वेस्टमेंट्स हैं कि उनको हम कंपेयर नहीं कर सकते आज का। पुट मनी टू वर्क रादर देन एक्यूमुलेटिंग और कीपिंग इट आइडल। हमेशा ध्यान रखें, पैसा आपको इन्वेस्ट करके रखना है। कहाँ करना है हम डिस्कस कर लेंगे, लेकिन कहाँ नहीं करना है बहुत इंपॉर्टेंट है, क्योंकि बहुत सारे लालच हमारे पास आते हैं। ऑनलाइन गेमिंग बहुत सारा बड़ा शौक है यूथ का, यंगस्टर्स का। ड्रीम 11 की टीम बना लीजिए, लूडो, बिंगो, 3 पत्ती, इस टाइम भी खराब करेंगे, पैसा भी खराब करेंगे। चिट फंड्स मतलब है ये, लोग BC भर देते हैं। आप देखा होगा आसपास में एटमॉस्फेयर, इसका क्रूड रूप तो हम घरों में देखते हैं, पर मार्केट प्लेस में देखते हैं लोग ग्रुप बना के पैसा करते हैं। क्रेडिट कोऑपरेटिव सोसाइटी के नाम पे बैंक वाले हमारे पास आते हैं, आदर्श क्रेडिट, संजीवनी क्रेडिट, सहारा क्रेडिट, इस तरह के लोग आते हैं जो हमें बहुत ऊंची ब्याज का लालच देते हैं और पैसा देके जाएगा। मत करिए, क्योंकि हमारे पास बहुत सारे ऑप्शन सेबी ओरिएंटेड और रेगुलेटेड ओरिएंटेड हमारे पास बहुत सारे हैं जहां हम अपना पैसा लगा सकते हैं। नेवर डिपेंड ऑन सिंगल इनकम, मेक इन्वेस्टमेंट्स टू क्रिएट ए सेकंड सोर्स। वॉरेन बफेट का बहुत बड़ा स्टेटमेंट है, कभी भी आप इसके बारे में पढ़ना चाहें पढ़ सकते हैं, बहुत अच्छी तरह समझाया उन्होंने। लेकिन हमें वेल्थ बिल्ड करने की जरूरत क्या है, आवश्यकता क्या है, क्यों? क्योंकि फ्यूचर इज अनसर्टेन। सबसे बड़ा दुश्मन है हमारी इन्वेस्टमेंट का, हमारी सेविंग का, इन्फ्लेशन। सबकी कॉस्ट ऑफ लिविंग बढ़ती जा रही है, उस प्रोपोर्शन में इनकम नहीं बढ़ी है। मान के चलिए कि एजुकेशन, मैरिज, रिटायरमेंट इज एवरीथिंग इज राइजिंग। एंड बिलीव मी, कोई भी चीज ऐसी नहीं है जो एक्सीडेंट है। आप आज आए और आपको कहा कल आप रिटायर हो गए। आपका बच्चा आया और उसकी कल शादी करनी है, आज बच्चा हुआ, उसके हायर एजुकेशन तक आपने कुछ नहीं सोचा। ये सारी चीजें प्लान की जा सकती हैं। एंड बिलीव मी, इन्वेस्टमेंट के जरिए और म्यूचुअल फंड के जरिए आप इन सब चीजों को बहुत अच्छी तरह प्लान कर सकते हैं। ओनली थिंग इज वी नीड टू सिट विद ए पेन एंड पेपर विद द फैमिली एंड प्लान आवर। एक लाइफ साइकिल तो है हमारी, शादी हुई, बच्चे हुए, बच्चों की एजुकेशन हुई, घर लिया, हमने गाड़ी ली, बच्चों की शादी की, इमरजेंसी फंड बनाया, फिर हम रिटायर हुए। एक टिपिकल लाइफ साइकिल हम लोग जीते हैं, और उस टिपिकल लाइफ साइकिल में शायद हमारे लिए फाइनेंशियल गोल्स भी हैं, पर हम डिस्कस नहीं, वी नेवर प्लान। आज देखिए 31 का महीना क्यों बनाया भगवान ने? 30 का महीना ठीक था ना? 31 का महीना एक दिन हमें भगवान ने एक्स्ट्रा इसलिए दिया कि हम ये समझ पाए घर वालों के साथ बैठ के कि हमारे फाइनेंशियल गोल्स क्या है, जो इन्वेस्टमेंट हमने किए वो अपने मुताबिक चल रहे हैं कि नहीं चल रहे हैं, डू रिक्वायर ए चेंज, हमें उसको चेंज करना है कि बदलना है, कि फाइनेंशियल एडवाइजर को बदलना है या फाइनेंस के प्लान को बदलना है। एक दिन बैठ के आप रखिए, सब चीज़ों को नोट डाउन कर रखिए। टाइम के साथ, फ्यूचर के टाइम हम भी अनसर्टेन है। एक बहुत अच्छी बुकलेट मैंने आपको सबको प्रेजेंट की है, इसका इलेक्ट्रॉनिक वर्जन भी मैं डॉक्टर साहब को भेजूंगा कि वो सबको दे दें। इसको ईमानदारी से भर लीजिए आप, बिलीव मी आपके पास सारा कुछ अच्छा होगा। सब कुछ इसको ईमानदारी से भरिए, मेरे को नहीं भेजना, मेरे साथ किसी के साथ में शेयर नहीं करना, पर आप अगर ईमानदारी से इस 12 पेज की बुकलेट को भर लेंगे तो शायद आपके पास अपनी सारी फाइनेंशियल पोजीशन बहुत अच्छी तरह क्लियर होगी। एंड बेस्ड ऑन दिस डॉक्यूमेंट यू कैन प्लान योर फ्यूचर, यू कैन प्लान योर फैमिली एंड राइट ए विल आल्सो। आप बहुत बड़ा डॉक्यूमेंट है, इसको विल कहते हैं, उसको भी आप बना सकते हैं। तो इस डॉक्यूमेंट को बहुत ध्यान से आप पढ़ लीजिए। बेटर हाउसिंग, बेटर व्हीकल, फॉरेन टूर्स, बहुत सारी एस्पिरेशन हम लोगों की है, लेकिन हमें उसके लिए वेल्थ की जरूरत है। काम करने के लिए, खाने के लिए तो पैसे बहुत सारे होंगे, जिस स्टैंडर्ड, जिस बैकग्राउंड से हम लोग हैं उसमें हमारे पास कोई कमी नहीं है, पर आगे बढ़ के इन चीज़ों को हमें करना है तो उसको हमें करना ही पड़ेगा। और एक रिटायरमेंट वाला, एक बियॉन्ड एज हम लोग ज़्यादा काम भी नहीं कर सकते, और अगर हम ज़्यादा काम नहीं कर सकते तो हमें ये देखना पड़ेगा कि हम उस एज के लिए भी बचा के रखें जो हमें पैसा चाहिए। 100 रुपीज़ 1990 में बड़ा प्राउड होता था कोई 100 रुपीज़ का नोट देता है। आज 2023 में हालांकि बंद हो गया, फिर भी 2000 की वैल्यू के बराबर में 100 की वैल्यू आज की तारीख में नहीं है। तो ये इन्फ्लेशन है। सवाल जरूर पूछने, मैं बार बार अपने आप से पूछता हूँ, आप लोगों से पूछता हूँ, आपको भी ये सवाल पूछने कि अपने चाइल्ड की एजुकेशन कॉस्ट क्या होगा, बच्चों की वेडिंग कॉस्ट क्या होगी, नए बड़े मकान की कॉस्ट क्या होगी, क्या वो कार जो मेरी ड्रीम कार है क्या मैं उसको परचेज कर पाऊंगा, क्या रेनी डेज में, ओल्ड डेज में मैं वही स्टैंडर्ड मेंटेन कर पाऊंगा जो आज मैं कर रहा हूँ, क्या मेरी फैमिली को मैं फॉरेन ट्रिप पे ले जा सकता हूँ। ये बहुत सारे सवाल हैं जो हम अक्सर पूछा करते हैं अपने आप से, और कई बार गोल गोल जवाब नहीं मिल पाते। क्यों? क्योंकि हमने सेविंग नहीं की, और सेविंग की तो हमने इन्वेस्टमेंट नहीं की। इन सब चीज़ों को आप थोड़ा सा फिगर से समझाने की कोशिश करता हूँ कि 35 की एज पे अगर आपने 6% पे आपका घर का खर्च 50,000 रुपये है, तो दोस्तों मान के चलिए कि 60 ईयर्स की एज पे यानी 26 साल बाद 2046 में वो 2,14,000 रुपये होगा। आज जो 50,000 का एक्सपेंस है। फिर बता रहा हूँ आपको, रिक्वेस्ट टू यू कि मैं आपको डरा नहीं रहा, दीज आर फैक्ट्स, एनीबडी कैन कैलकुलेट ऑन पुट ऑन ए कैलकुलेटर, ये हो जाएगी। और मतलब क्या है कि इन चीज़ों को हम उस जगह ले जाएं, हम अपनी सेविंग्स को, हम अपने इन्वेस्टमेंट को इस जगह ले जाएं कि इस तरह के रिटर्न आए, ताकि हमें पीछे मुड़ के देखने की आवश्यकता ना पड़े। हिस्टोरिकल रिटर्न, बहुत सारी चीज़ें हम लोग एसेट एलोकेशन के टाइम में ध्यान रखते हैं, लेकिन उन सब चीज़ों को आप ध्यान रखिए। तो जो S&P BSE इंडेक्स है, जिससे 15.9% का एग्जाम्पल दिया, तो डॉक्टर रवि से बात हो रही थी, विप्रो के शेयर, किसी बंदे ने 10,000 का शेयर दिया, उसके 500 करोड़ से ज़्यादा के शेयर की वैल्यू। सिंपल, जो 1979 में 100 का इंडेक्स चला, वो आज की तारीख में 65,000 का है, मतलब 15.9% का हिस्टोरिकल रिटर्न है। गोल्ड सबसे प्रिय होता है 9.8%, आप बैंक FD 8.1%, और एवरेज इन्फ्लेशन 7.1% माने तो आज की तारीख में मानना पड़ेगा कि इक्विटीज परफॉर्म बेटर। और अगर ये ध्यान रख लें और हम बहुत केयर के साथ में इक्विटीज में इन्वेस्टमेंट करें, और हमें इक्विटी पता नहीं है तो हम म्यूचुअल फंड के जरिए निवेश करें, कोई भी ताकत हमें रोक नहीं सकती। ओनली थिंग इन्वेस्टिंग इनटू इक्विटी, शेयर मार्केट सबको ललचाता है, मैं वर्ड यूज कर रहा हूँ ललचाता है, क्योंकि इतनी क्विक मनी, बहुत सारी क्विक मनी देखने को मिलती है। मिलती कि नहीं मिलती, ये मेरे 35 साल के इतिहास में बताता हूँ, नहीं मिलती। सर, एक शेयर ब्रोकर के यहाँ बोर्ड लगा हुआ है, यहाँ लखपति बनाए जाते हैं, और नीचे ब्रैकेट में लिखा जो पहले कभी करोड़पति थे। अब उस सिनेरियो में आप देखिए कि मैं स्टॉक को कैसे चुनूं, हाउ टू सेलेक्ट इन्वेस्ट, कौन सी कंपनी अगर फेल हो गई तो प्राइजेज नीचे गिर गई तो मेरे को तो पता ही नहीं। आप सुबह क्लिनिक जाते हैं या जॉब पे जाते हैं, शाम तक आते हैं, तब तक जो मटियामेट होना है मार्केट में हो चुका होता है। कितना इन्वेस्ट करना है ईच स्टॉक में, और प्रॉफिट कब वो करना है, क्योंकि जब शेयर मार्केट बढ़ रहा होता है तो लालच हमारा बढ़ रहा होता है, और जब गिर रहा होता है तो डर हमें सताता है, पता नहीं क्या हो जाएगा। हम दोनों केस में नहीं खरीद सकते और नहीं बेच सकते, और इसका सबसे बढ़िया आंसर है म्यूचुअल फंड्स। बेस्ट आंसर, somebody is working for you, a team of qualified, trained, certified, verified and appointed, जो उनका वेरिफिकेशन होता है बाय टॉप नॉच बॉडी कॉल्ड सेबी, आपका म्यूचुअल फंड पे मैनेज करते हैं। एसेट एलोकेशन आप कर सकते हैं तो बहुत बढ़िया, आप नहीं कर सकते तो म्यूचुअल फंड वाला कर लेगा। आपको फंड सेलेक्ट करना है, प्रॉपर्टी में इन्वेस्ट करिए, गोल्ड में इन्वेस्ट करिए, आर्ट कलेक्शन में इन्वेस्ट करिए, इक्विटी शेयर में इन्वेस्ट करिए, बॉन्ड्स में, नेशनल सेविंग सर्टिफिकेट्स है, PPF है, बैंक कंपनीज पॉलिसी, सारी चीज़ें घूम के कहा जाएगी, आपको सारी चीज़ें मिल जाएगी किसी अच्छे म्यूचुअल फंड। जरूरत है आपको एक सिर्फ अच्छे ट्रेंड सर्टिफाइड म्यूचुअल फंड एडवाइजर की या पोर्टफोलियो एडवाइजर की, जो आपको बता दे कि कौन सी राइट एसेट क्लास का कौन सा मिक्स है। 100 रुपीज़ हैं आपके पास इन्वेस्ट करने के लिए, मत डालिए म्यूचुअल फंड में। 100 रुपीज़ हैं आपके पास इन्वेस्ट करने के लिए, मत खरीदिए गोल्ड। आप इसको थोड़ा सा एसेट एलोकेशन करके देखिए, आपके रिस्क भी बढ़ जाएगी, आपके रिटर्न्स भी बढ़ जाएंगे। 10 रुपये आप डालिए सोना चांदी में, कुछ भी कर लीजिए। आप किसी को भी मना कर दिए कि सोना चांदी मत खरीदिए, खरीदेगा। 5 रुपये डालिए पीपीएफ में, 10 रुपये लैंड बिल्डिंग में, 20 रुपये म्यूचुअल फंड में, 10 रुपये बॉन्ड्स में, 20 रुपये आप शेयर्स में लगाइए, 10 रुपये कैश रखिए, एसेट एलोकेशन कर लीजिए। तो क्या होगा, आपकी रिस्क भी डाइवर्सिफाई होगी और आपकी रिटर्न्स भी बढ़ेंगे। म्यूचुअल फंड्स सब लोग समझते हैं, लोग टर्मिनोलॉजी बड़ी कॉमन है। पूल ऑफ इन्वेस्टर्स, कॉमन इंटरेस्ट के साथ में जब लोग पैसा लगाना चाहते हैं तो एक प्लेटफॉर्म ढूंढते हैं। 1987 में सबसे पहला म्यूचुअल फंड यूनिट ट्रस्ट ऑफ इंडिया ने चालू किया। आज की तारीख में 51 म्यूचुअल फंड है भारत में, जिनकी टोटल वर्थ है 45 लाख करोड़। आज सारे मिलकर हम जीरो लगाए पूरी बिल्डिंग में तो नहीं पूरा कर पाएंगे, इतनी जीरो लग जाएंगे। 45 लाख करोड़, कई देशों की तो इकोनॉमी नहीं होगी। बट रिवर्स फैक्ट क्या है, खाली 7 करोड़ से ज़्यादा, 7 करोड़ के आसपास म्यूचुअल फंड के होल्डर्स हैं, जिसमें भी कहीं डबल होंगे। तो आप देखिए, इतनी बड़ी अच्छी इंडस्ट्री में लोग विश्वास नहीं करें। क्यों नहीं करें? गॉड नोस। क्योंकि हर बार हम डायरेक्ट क्या करते हैं, उसको म्यूचुअल फंड को शेयर मार्केट में ले जाते हैं, और शेयर मार्केट से लगता है तो म्यूचुअल फंड में जाते हैं। जबकि देयर इज ए स्ट्रॉन्ग वॉल, फर्स्ट ऑफ योर म्यूचुअल फंड एडवाइजर, सेकंड ऑफ म्यूचुअल फंड मैनेजर। आपको सुन के अच्छा लगेगा, सेबी ने इतने कानून लगा रखे हैं कि आज अगर आप पिछले 23 साल के लिए गूगल करके देखें तो आप गूगल पे ये नहीं फाइंड आउट कर पाएंगे कि केवल म्यूचुअल फंड पैसा लेके भागा। यस, कोई म्यूचुअल फंड पैसा लेके भागा या फाइंड आउट नहीं कर पाएंगे। रिटर्न्स 6% हो सकती है, 8% हो सकती है, 10% हो सकती है, 14% हो सकती है, 28% हो सकती है, तो पैसा लेके भाग गया आप नहीं सकते। फंड मैनेजर जो अपॉइंट होता है फंड में, सर उसको अपनी सैलरी का 30% उस फंड में मैंडेटरली इन्वेस्ट करना है जिस फंड को मैनेज कर। ये सेबी का कानून है। आपने पहले होता है पायलट, कुछ गड़बड़ हुई, उसने अपना को इजेक्ट कर लिया। आजकल इजेक्शन का बटन हटा दिया सब हवाई जहाज से। पायलट हैज टू डाई विद द फ्लाइट, प्लेन के साथ में बनना जरूरी है। उसको बहुत अच्छी तरह समझिए कि म्यूचुअल फंड में बहुत अच्छी लिक्विडिटी है। पूल करके इन्वेस्टर्स का पैसा लगा है, फंड मैनेजर है, स्टॉक सिक्योरिटीज है, रिटर्न्स आपके सामने। क्या फायदा है? लो कॉस्ट। कितनी कॉस्ट दे रहे हैं आप? एक टोटल एक्सपेंस रेशियो सेबी ने डिसाइड कर दिया है, 1%, 1%, 1.25%, इससे ज़्यादा नहीं। और वो भी आपको नहीं देना, तो पूल में लगना है। आपने कोई डायरेक्ट पैसा नहीं देना, 1% मान लीजिए सबसे लो कॉस्ट में आपने पैसा लगा दिया। इन छोटा सा अमाउंट एज लो एज 100 रुपीज से भी आप म्यूचुअल फंड में ऐसा ही चालू कर सकते हैं। व्हाट इज रॉन्ग? आप 100 से चालू करिए, 1 लाख से करिए, 10 लाख से करिए, आप करिए आराम से। प्रोफेशनल मैनेजमेंट है। हर बंदा जो म्यूचुअल फंड इंडस्ट्री में काम कर रहा है, ही इज सर्टिफाइड बाय NISM, नेशनल इंस्टीट्यूट ऑफ सिक्योरिटीज मैनेजमेंट। मैं भी खड़ा हूँ आपसे, DCO सर्टिफिकेट मेरे पास है। बिसाइड इसके कि मैं अहमदाबाद का प्रोफेशनल हूँ, SK अहमदाबाद का प्रोफेशनल हूँ, क्वालिफाइड चार्टर्ड अकाउंटेंट, कंपनी सेक्रेटरी हूँ। बावजूद इसके NISM मैंने पोर्टफोलियो मैनेजमेंट, AIF, म्यूचुअल फंड डिस्ट्रीब्यूशन सारे सर्टिफिकेशन पास करके। तो आप समझिए कि इतना कठोर प्रतिबंध है कि कोई दाएं वाला बंदा आपको डिलीवर नहीं कर सकता चीज़ों को। वेल रेगुलेटेड बाय सेबी। आप रिस्क डाइवर्सिफिकेशन कर रहे हैं। आपने 1 लाख रुपए में रिलायंस के शेयर खरीद दिए, कुछ गड़बड़ हो गई तो 1 लाख रुपए में कुछ भी बहुत बड़ा नुकसान हो सकता है। वहीं 1 लाख रुपए आपने म्यूचुअल फंड में लगा दिया, 40 कंपनियों में खरीदेंगे, 40 की 40 कंपनियां बंद हो गई तो आप पैसा करेंगे भी क्या? और ये संभव ही नहीं। आपका रिस्क डाइवर्सिफाई हो जाएगा। लिक्विडिटी है, जब पैसा चाहिए आप OTP डालिए, अपना रिडेम्पशन कर लीजिए, तीसरे दिन सुबह और आने वाले समय में दूसरे दिन सुबह आपके पास पैसा आ ही जाएगा। ट्रांसपेरेंसी है। आप बैंक में 10 लाख रुपए की एफडी करा दी, बैंक मैनेजर से पूछ के बता दीजिए कि मेरे 10 लाख रुपए आपने किसको लोन में दिए, नहीं बताएगा। आप 10 लाख रुपए लगाइए म्यूचुअल फंड में, वेबसाइट पे जाइए, फंड का देखिए कौन कौन सी कंपनी में आपके 10 लाख रुपए लगे, बिल्कुल ट्रांसपेरेंट तरीके से। तो इतनी सारी सुविधाएं हैं म्यूचुअल फंड में, आप करना चाहे तो। स्ट्रक्चर क्या है? इन्वेस्टर्स, स्पॉन्सर्स, ट्रस्टीज, कस्टोडियन, बैंकर्स, फंड अकाउंटेंट, इतनी जगह डाइवर्सिफाई है। और सारे के सारे लोग किससे जुड़े हुए हैं? वो सारे के सारे लोग हैं जुड़े हुए उससे आपके सेबी के गवर्नेंस, हर तरह का कानून उसमें आपको दिया हुआ है। ऑब्जेक्टिव है, हर तरह के फंड्स हैं आपके पास में, ओपन एंडेड फंड है, आपके पास ग्रोथ फंड्स है, आपके पास टैक्स सेविंग के लिए फंड्स हैं, आपके पास एक्सचेंज ट्रेडेड फंड है, आपको गोल्ड फिजिकल नहीं खरीदना तो गोल्ड के लिए फंड है, आपको सिल्वर नहीं खरीदना ETFs हैं आपके पास, आपको टैक्स बचाना इक्विटी लिंक सेविंग प्लान्स हैं जो 12 से 14% का दे रहे हैं, जबकि 15% की रेस्ट्रिक्शन के साथ में आप PPF लगाते हैं तो 6.9% है। आप 15 के बजाय 3 साल के रेस्ट्रिक्शन के साथ में, लॉक इन के साथ में ELSS में करिए, आपको 12 से 14% आपको फायदा। आप छोटे बच्चे हैं जो 0 से 18 ईयर्स के, उनके लिए आप प्लान करिए, बहुत सारा आपको आगे पैसा मिल सकता है। तो इन सब चीज़ों को देख के इक्विटी कैटेगरी में है, सेबी ने खुद ही डिसाइड कर दिया कि 1 to 100 लार्ज कैप, 101 से 250 मिड कैप, 250 एंड अबव स्मॉल कैप। मतलब आपके रिस्क को मेजर करने का तरीका आपको यार्ड स्टिक दे दिया सेबी ने कि आपके कोई भी एडवाइजर या कोई भी फंड हाउस आपका फूल नहीं कर सकता। सब कुछ चीज़ें आपके सामने हैं। सिस्टमेटिक इन्वेस्टमेंट प्लान मेरा बहुत कोर सब्जेक्ट है, दिल का सब्जेक्ट है कि आप एक डिसिप्लिन इन्वेस्टर कब बन सकते हैं, जब आपने रेगुलर डिसिप्लिन अपनी ज़िंदगी में डाला कि 1 तारीख को मेरे पास पैसा आया, 5 तारीख को मेरे पास पैसा आया, 6 तारीख को मैंने इन्वेस्ट कर दिया। वी कैन नॉट बी सो रेगुलर एक्सेप्ट SIP, सिस्टमेटिक इन्वेस्टमेंट प्लान। ऑटोमेटिकली आपके बैंक अकाउंट से पैसा जाएगा, म्यूचुअल फंड में इन्वेस्ट होगा, उसी दिन को आपको एनर्जी मिलती है। सेम डे आपके फाइनेंशियल गोल को आप सेट कर लीजिए, अपना SIP तय कर लीजिए। रुपी कॉस्ट एवरेजिंग का बेनिफिट है। जरूरी नहीं कि 5 तारीख को आपकी SIP हिट होगी उस दिन मार्केट अप ही होगा, जरूरी नहीं कि 5 तारीख को आपकी SIP हिट होगी उस दिन मार्केट लो ही होगा, पर 12 महीने में आपने रैंडम इन्वेस्टमेंट किया और SIP से किया, आपको मान के चलिए कि आपको यूनिट्स ज़्यादा मिली होंगी, क्योंकि रुपी कॉस्ट एवरेजिंग आपकी। बेनिफिट्स ऑफ कंपाउंडिंग बहुत अच्छी तरह समझिए, इतना अच्छा बेनिफिट है कंपाउंडिंग का। और सारे आप कैसे कर रहे हैं, ये सारे काम कैसे कर रहे हैं, बिना किसी एफर्ट के आपने एक एडवाइजर से सलाह करके किसी अच्छे म्यूचुअल फंड में अपनी SIP चालू कर दी। जादू SIP का मैं बताता हूँ। आप में से कितने लोग हैं जो अगले 5 साल में करोड़पति बनना चाहते हैं? तुम तो आप
ये 1 साल में बनना चाहिए,
नहीं बनना,
ये 1 साल में,
एक में भी नहीं। अभी टाइम टू स्पेंड। यस, हाँ, थोड़ा सा। कितने लोग हैं अगले 5 साल में करोड़पति बनना चाहिए? डॉक्टर साहब ने हाथ लगाया।
तो 1 साल में बनेगा।
आपको इतना सा करना है डॉक्टर साहब कि 1,22,500 रुपये पर मंथ की एक SIP चालू। ज्यादा हो गया? चलिए, दूसरा ऑप्शन है, आप 43,400 रुपये की 10 साल के लिए SIP चालू कर दीजिए। ज़्यादा है? कोई बात नहीं, 10,100 रुपये की पर मंथ की SIP चालू कर दीजिए 20 साल के लिए। नहीं तो कोई बात नहीं, एक BPL ऑप्शन भी है। 2800 रुपये की SIP चालू कर दीजिए 30 साल। Why I am giving this paradigm to all of you? Start early. कोई जादू नहीं है इसमें, सब कुछ ये कैलकुलेशन का फेयर है। आज मैं एक छोटा सा एग्जाम्पल डॉक्टर साहब हमेशा दिया करता हूँ, क्योंकि यंगस्टर्स भी पीछे बैठे हुए हैं। 20 साल की उम्र में 1,000 रुपये से आपने एक SIP चालू की, 1000 रुपीज़ पर मंथ, विद एन एम कि 60 साल में आपको रिटायर होना है। एक महीने में कितना जमा किया? 1000 रुपीज़। 12 मंथ्स में 12,000 रुपीज़ एंड 40 ईयर्स में आपने 4,80,000। 12% का स्टैंडर्ड अगर हम फार्मूला लगा लें तो 60वें साल के बंदे को मिलेंगे 1 करोड़ रुपये। तो यही 15% रिटर्न आए जो अमूमन आती है तो उसको मिलेंगे 2,57,05,000। मैजिक इज सिंपल। और यही चीज़ मैं अपने आप से लेके देता हूँ सब यंगस्टर्स को। जब भी मैं कॉलेज में जाता हूँ, प्रोफेशनल इंस्टीट्यूशन जाता हूँ, बताता हूँ कि मैं इससे कम्पीट करिए, आई एम रेडी टू कम्पीट। तो मैं उस बंदे से 60 साल जो 20 साल की उम्र में है, जिसने 1,000 रुपया चालू किया, उससे मैं ये कहता हूँ कि मैं 60 साल का हूँ, मैं 60,000 रुपये पर मंथ इंटरेस्ट इन्वेस्ट करूँ। किसको फायदा होगा? एज कंपेयर टू 1,000 रुपीज़ ऑफ ए यंग चैप ऑफ 20 ईयर्स, मैं उससे कंपटीशन कर रहा हूँ, मैं 60,000 रुपीज़ पर मंथ जमा कर रहा हूँ। किसको फायदा बताइए? क्यों 1000 वाले क्यों? मैं तो उससे 60 गुना ज़्यादा जमा कर रहा हूँ। टाइम इज क्रिटिकल। एट एज ऑफ 60 आई कैन नॉट गारंटी कि मैं और 40 साल जीऊंगा अभी। एट 60 आई कैन नॉट गारंटी कि 60,000 रुपीज पर मंथ जमा करने लायक इनकम मेरी अगले 40 साल तक होगी। द वेरेज ए यूथ ऑफ 20 years कैन यस गारंटी 1000 रुपीज ए मंथ स्टार्ट। छोटा सा एग्जाम्पल दूसरा समझ लीजिए। मिस्टर ए ने 25 साल की उम्र में अपना इन्वेस्टमेंट चालू किया 5,000 रुपये का, 12% की रिटर्न है। 55 साल 60 साल में बच्चे आजकल युवा बिलीव नहीं करते। मेरे पास ऐसे लोग हैं जो 35 साल 40 साल में भी रिटायर होना चाहते हैं। टोटल इन्वेस्टमेंट 18 लाख का और उनको मिलेगा 1,76,00,000। तब समझिए 45 साल की एज में मिस्टर सी ने चालू किया, ट्रिपल द अमाउंट 15,000 रुपया, सेम 12% की रेट है। 55वें साल पर रिटायर होना है। 18 लाख उसने भी जमा किए, उसको मिलेंगे 34 लाख। दिस इज द डिफरेंस। ये डिफरेंस है जो आपको देखना है। ये क्रिटिकल चीज है, लेकिन सब लोग नहीं करते। क्यों नहीं करते? प्रोकास्टिनेशन। मेरे पास टाइम नहीं है, मैं तो नहीं करूँगा, मेरे पास पैसा नहीं है, मेरे पास पेपर वर्क करने का टाइम नहीं है, आई डोंट हैव द रिक्विजिट स्किल्स। दोस्तों ये सारे काम आपको नहीं करने हैं। सेबी ने सबको असाइन कर दिए हैं, म्यूचुअल फंड एडवाइजर को, पोर्टफोलियो मैनेजर्स को, फंड मैनेजर्स को, एएमसीज को, जो आपके लिए काम करती है। आपको कुछ नहीं करना। आप कई सारी मीथ में जीते हैं कि म्यूचुअल फंड आर फॉर द एक्सपर्ट्स। नहीं, कॉमन मैन के लिए। म्यूचुअल फंड लॉन्ग टर्म के लिए नहीं, शॉर्ट टर्म में म्यूचुअल फंड ले सकते हैं आप। आज जमा करिए, कल भी निकाल सकते हैं पैसा। म्यूचुअल फंड इज ए इक्विटी प्रोडक्ट नहीं, म्यूचुअल फंड इज ए इक्विटी, राइट। तो इसको बस सिंपल फार्मूला है कि अर्ली स्टार्ट अर्ली, इन्वेस्ट अर्ली एंड क्रिएट वेल्थ। एक बहुत इंपॉर्टेंट टॉपिक है जो मैं आपको टच कर रहा हूँ, 2 मिनट लगेंगे। नॉमिनेशन एंड जॉइंट नेम। आपके बैंक अकाउंट में आपके जो भी इन्वेस्टमेंट है, मैं आपको जगह भी बता दूंगा कहाँ कहाँ करना है। करना क्या है, 3 तरह से आप समझिए। जॉइंट नेम और नॉमिनेशन की अहमियत क्या है? किसी भी एक बैंक अकाउंट में आप 3 लोग जॉइंट हो सकते हैं, किसी भी एक बैंक अकाउंट में आप 3 लोग नॉमिनेट कर सकते हैं, राइट। कितना टाइम लगता है इस काम को करने में? 5 मिनट। क्या मैं बदल सकता हूँ? यस, यू कैन चेंज एनी टाइम, ठीक है। क्या इस काम के लिए कोई फीस लेगा? नो, इस काम के लिए कोई भी फीस नहीं लेगा, कोई भी इंस्टीट्यूशन फीस लेगी। मेहरबानी करके ये 8 जगह जो मैंने बताई है, अगले 15 दिन में आप दोनों काम कर दीजिए। बैंक अकाउंट, फिक्स डिपॉजिट, आपके नेशनल सेविंग सर्टिफिकेट या पोस्ट ऑफिस अकाउंट, बैंक लॉकर्स, डीमेट अकाउंट, इंश्योरेंस, लाइफ, बाइक, कार, प्रॉपर्टी, आपका इन्वेस्टमेंट्स और पीएफ, अगर आपका कुछ प्रोविडेंट फंड का प्रोविजन है। अब इस चीज में एक बार देख लीजिएगा कि पहले 3 चीजें, बैंक अकाउंट, फिक्स डिपॉजिट और लॉकर, आपका एक ही बैंक अकाउंट से ऑपरेट हो रही है। लेकिन आपको 3 जगह इसलिए करना है कि जब आप घर जाकर देखेंगे तो तीनों अकाउंट नंबर आपको डिफरेंट मिलेंगे, तीनों चीजें डिफरेंट मिलेगी। तो आपको 3 जगह करना है, चाहे एक ही बैंक में, एक ही बैंक अकाउंट से आपका पैसा जा रहा है एफडी में, और उसी में से बैंक का लॉकर का पैसा डेबिट हो रहा है, आपको उसमें करना है। माय कनेक्शन हैज बीन गिवन टू यू। इफ यू ऑल वांट कि आपको करना है या आपको कुछ रीस्ट्रक्चर करना है, समझ सकते हैं इसको। कुछ चीजें जो सिविल के बारे में मेरे को बतानी थी, वो सिविल वाली चीज मैं आपको बताना चाह रहा हूँ, अगर टाइम परमिट तो आएगी।
यस क्वेश्चंस
सर रेलिवेंट है, अगर आप मेरे को कुछ टाइम देंगे तो जो आपने बात बताई है, मैं एक प्रैक्टिकल कहानी, सच्ची कहानी घटना पर्सनली के बता दूँ। माउंट आबू में मैंने अब रोड में मैंने जॉब शुरू किया था। मेरे सारे फ्रेंड ये अग्रवाल कम्युनिटी से ही, मैं तो जो आप बता रहे हैं वही कर रहा था। वो क्या कर रहे थे, प्लॉट ले रहे थे छोटे छोटे 2000 में उन्होंने 5-5 हज़ार के प्लॉट लिए थे मेरे हॉस्टल के पीछे। अब मेरे पास तो शायद मैं बताऊंगा नहीं, पर हाँ अभी मैं एक छोटी सी कार चलाता हूँ जो है, उनके पास उन्होंने क्या किया, सबके पास 100 से 200 करोड़ रुपए है, तो 5,000 का प्लॉट अभी 1 से 2 करोड़ के बीच में है। तो जो मेन बात आपने कही वो सेविंग की बात है, आप सेविंग करो किसी फॉर्म में, और दैट शुड बी डाइवर्सिफाइड। नंबर 2, जो उन्होंने, मैंने क्या किया, अपने बच्चे पढ़ाए सारे, उन्होंने क्या किया, डायरेक्ट बुक लिया। बोले डॉक्टर साहब ये तो कोई बात नहीं, एक बच्चे के नाम से हमने तो प्लॉट ले लिया, एक प्लॉट में एमबीबीएस हो गया, एक प्लॉट में पीजी बन गया, और 2 बच्चे उन्होंने एमडी रेडियो डायग्नोसिस बना के कर दिया। वैसे उनका जिला डायरेक्टर था, तो ये मैं ये कहना चाहता हूँ कि ये चीजें सही हैं, पर ये डेप्रिसिएशन है ना, वो बहुत दिक्कत आता है। जो 2000 में जो मैं सोचता था बहुत बड़ा कॉर्पस मिलेगा, माइक्रोस्कोप आता था 3 लाख का, अब सब 30 लाख का आ रहा है। 30 से शुरू होता है, 50 से आता है। तो पीस ऑफ लैंड आपके विसिनिटी में है, वो जरूर करना चाहिए, डॉक्टर्स को जरूर करना चाहिए, छोटे छोटे जहाँ नई जगह जरूर करना चाहिए। लेटली मेरे समझ में आया, तो नाउ आई एम ऑल्सो हैप्पी इन दैट वे। बट म्यूचुअल फंड की बात है तो वो भी होना चाहिए, वो भी हम लोग करते हैं। तो ये मेरा एक छोटा सा प्रैक्टिकल अनुभव था जो आपके साथ शेयर
नहीं, प्रॉपर्टी बोलते भी है, दादा खरीदे पोता भरते।
डॉक्टर साहब, इसमें मेरा कंटेंशन इतना सा है कि जैसे आपने एक लैंड को 25 साल पाला, वैसे ही म्यूचुअल फंड को अगर 25 साल पालेंगे तो आपको बहुत अच्छा एप्रिशिएशन मिलेगा, ये आप मान के चलिए।
सेम एप्रिशिएशन यू विल गेट।
आप डाइवर्सिफाई करें, कुछ पैसा लैंड में रखें, कुछ पैसा गोल्ड में रखें, कुछ पैसा आप म्यूचुअल फंड में रखें। मैंने कभी भी नहीं कहा आपको 100 रुपीज आपके पास तो 100 रुपीज आप म्यूचुअल फंड में लगा दें, नेवर।
सर एक चीज मैं ऐड करना चाहूंगा, आप प्रॉपर्टी बेचने जाओगे तो खरीदा 3 साल तक नहीं मिलेगा, लेकिन म्यूचुअल फंड और शेयर मार्केट में 3 दिन के अंदर अंदर आपके पास पैसा आ जाएगा, वो भी सेम रिटर्न में।
आफ्टर टॉक विल डिस्कस इन प्राइवेट, क्योंकि ये सारी चीजें ईडी इनकम टैक्स सुनने हैं, मेरे दोस्त ही हैं सारे, मैं आपको बताऊंगा, कोई जरूरत पड़ती नहीं है बेचने की।
चलिए, और कोई सवाल है तो पूछ लीजिए।
सर म्यूचुअल फंड्स आपने बताया, म्यूचुअल फंड्स में से निकलना कब चाहिए? अभिमन्यु तो निकलने के चक्कर में मारा है।
सर डॉक्टर साहब आपने तो पहले ही जवाब दे दिया था। सबसे पहले आपने अपना डॉक्टर साहब ने जवाब दिया, मेरे को टेस्ट करने के लिए पूछ रहे हैं। नहीं, आप सब पूछ रहे हैं, लोगों के लिए पूछ रहे हैं, पर आपने सबसे पहले जवाब दिया। हमेशा म्यूचुअल फंड इन्वेस्टिंग मस्ट बी गोल बेस्ड। आप जिंदगी में गोल बना कर रखिए। आप किसी एडवाइजर के पास चलिए, मेरे पास को छोड़ के ना, मैं तो नहीं सलाह देता ऐसे, किसी के पास चलिए, मार्केट बढ़ रहा होगा, बहुत अच्छा टाइम में पैसा लगाओ, जब गिर रहा होगा अभी मत निकालना, तो पैसा जमा करके लिए।
क्वेश्चन लिटिल डिफरेंट, अदर देन गोल्स, क्या बीच में उसकी परफॉर्मेंस देख के हमें खाली सिंपल करनी है या उसमें से निकलना भी है, वो क्वेश्चन।
डॉक्टर साहब, अगर आपने एक अच्छा फंड सेलेक्ट किया है तो आप इक्विटी फंड है तो 5 साल के लिए भूल जाइए, 5 साल 7 साल चलाइए। पैसा निकालना बड़ा आसान है, एक OTP डालिए, आपको कैश की साइड में आपका पैसा आ जाएगा। पर आप मेरे को बताइए कि घर में लेडीज गोल्ड खरीदती हैं, ये कहते हैं गोल्ड टाइम में पैसा मिल जाएगा, किसी ने गोल्ड बेचा आज तक? डॉक्टर साहब कह रहे हैं लैंड बेचना बड़ा आसान है, नहीं है। आप जब बेचने जाएंगे डाइवर्स कंडीशन में तो आपको लैंड के आधे पैसे मिलेंगे, और म्यूचुअल फंड है आप आज डालिए, तीसरे दिन सुबह पैसा आ जाएगा। तो हम इतने लिक्विड चीज को इतने लिक्विड तरीके से ना डील करें, और जब टेम्परेरी प्रॉब्लम है तो परमानेंट सॉल्यूशन ना ढूंढें। और म्यूचुअल फंड में भी बहुत अच्छी बात है, 60% तक का लोन आपको अगले 15 मिनट में आपके अकाउंट में मिल जाएगा। तो अगर आपको टेम्परेरी प्रॉब्लम है तो ना उसको तोड़ें, आप लोन अगेंस्ट सिक्योरिटी। यस, सवाल
चलो ठीक है, थैंक यू सर।
ठीक है सर।
तो मैं चाह रहा हूँ कि पीछे यंगस्टर्स बैठे ना, आई एम श्योर आप गलती से आए इस रूम में।
नेक्स्ट वाले
एक दो सवाल पूछ लीजिए आप, बिलीव मी, अच्छा लगेगा। एक दो, हाँ।
जैसा आपने बोला कि नॉलेज बहुत कम होती है हम लोगों को, क्या SIP है, क्या चीज़ है, इससे रिलेटेड ऑब्वियसली वाला टाइम लैकिंग हमारे पास रहता है। हम उस चीज़ में जब कुछ सोचते हैं कि पैसा डालें तो सबसे पहली चीज़ ये आती है कि पैसा डूब जाएगा तो क्या करेंगे। जो ऑप्शंस अवेलेबल है कि आपको चीज़ें सेफ ऑप्शन ओके, बट हाउ टू अंडरस्टैंड बेसिक चीज़ क्या है उसके बारे में अगर आप खुद पढ़ के थोड़ी सी नॉलेज लेना चाहिए तो क्या सोर्स रह सकते हैं?
आप देखिए सेबी की साइट पे बहुत सारे आपको मिल जाएंगे, आपको लेसन्स BSc IPF की साइट पे बहुत सारे मिल जाएंगे। यूट्यूब पे मत जाइए, फेसबुक पे मत जाइए, वहाँ जो सेल्फ प्रोक्लेम पंडित है वो आपको भ्रामक कर देंगे, आपका पैसा डुबो देंगे। या फिर किसी म्यूचुअल फंड एडवाइजर, जो फाइनेंशियल एडवाइजर है, आर्थिक सलाहकार है, उससे मिल लीजिए। एक्सपेरिमेंट मत करिए, पैसा कमाना बड़ा मुश्किल है, खोना बहुत आसान है। यस,
चलो ठीक है, थैंक यू।
Our last speaker, 5 to 7 minutes.
एजुकेशन के बारे में आपने बहुत अच्छा क्वेश्चन पूछा। ये सब जैसे पीजी आपकी फर्स्ट ईयर स्टार्ट होती है, फर्स्ट मंथ से आपको इन्वेस्टमेंट स्टार्ट कर देना चाहिए। एजुकेशन आप कैसे लेते हो, आपकी ट्रेनिंग होती है, आपको रिलेट करो अपने प्रोफेशन से। आप फैको सर्जरी स्टार्ट करते हो क्या पहले दिन से थोड़ी स्टार्ट करते हो? आप पहले पेशेंट देखना शुरू करते हो, पहले रेटिनोस्कोपी करते हो, रिफ्रैक्शन करते हो, फिर डीसीटी देते हैं, फॉरेन बॉडी रिमूवल देते हैं, उसके बाद फिर आपको ऐसे ही से स्टार्ट करते हैं, फिर स्टार्ट कराते हैं आपके भी इंसिजन कैसे बनाए, रेक्सिस कैसे बनाए, ऐसे ही आपका जो फाइनेंशियल नॉलेज है धीरे धीरे करके ऐसे बढ़ेगी। स्टार्टिंग में यू टॉक टू एनीवन हु इज एक्सपर्ट और हु इज डूइंग सम इन्वेस्टमेंट बिफोर, so they will guide you how to start your investment. Mind it, जब तक आप इन्वेस्ट नहीं करेंगे तब तक आपको ये नहीं पता चलेगा कि मेरे को मेरा फ्यूचर कैसे अपने फाइनेंशियली सेव करना है। I will focus on for doctors how to start investing in stocks because every topic is being covered. मैं केवल ये आपका डर दूर करना चाहता हूँ कि आप शेयर मार्केट में या म्यूचुअल फंड में आप इन्वेस्ट करें तो आपका डर कैसे दूर होएगा। आप ये देखिए अभी एक बात चली थी कि 1980 में अगर किसी ने 10,000 जमा किए, इन्वेस्ट करके छोड़ दी विप्रो में एंड वो सो गया, फिर वो 35 साल के बाद उठा 2023 में, आप सोच सकते हो उसकी वैल्यू कितनी होगी? 9,000 करोड़ से 900 करोड़ से ऊपर, अभी भी 1,000 करोड़ के आसपास है उसकी वैल्यू। दिस पर्सन इज स्टिल लिविंग in Maharashtra. Similarly, why can't you? Only thing is start early. सबसे मेन फैक्टर क्या है इसमें? केवल टाइम। मैं थोड़ा जल्दी जाऊंगा पर मेन टॉपिक में आता हूँ। टाइम, ओनली थिंग इन्वेस्ट एंड स्लीप ओवर इट एंड दैट्स ऑल, सिंपल। लेट द मनी अर्न फॉर यू व्हाइल यू आर स्लीपिंग, अदरवाइज यू विल हैव टू वर्क टिल यू डाई. Only thing is start your investment as early as possible from the first salary, first stipend in your PD. That thing. And why do we invest? To beat inflation and all these things. ये हमारे goal है. And main thing is retirement. When you become 65, 60, you have to be just money आता रहे, financial independence हो जाए. That retirement can be done at 45 years age. Or some people they are at 20 years also. Those who have started or the parents they have started, they have invested in the at the time of birth. Now सेविंग अकाउंट 2.5% है। जो बैंक आपको क्यों देगा 2.5 और 5%? क्योंकि वो आपको लोन देता है, लोन से वो आपको 10% कमाएगा और आपको देगा 5% एफडी के ऊपर। इसी तरह से बैंक जो है आपके म्यूचुअल फंड में जमा कराएंगे और आपको देंगे 10%। म्यूचुअल फंड अल्टीमेटली वो शेयर मार्केट में जाता है, शेयर मार्केट 30-40% कमाएगा क्योंकि वो आप फाइनेंशियल एडवाइजर बैठे होते हैं, बेसिकली फाइनेंशियल प्लानर। तो स्टॉक मार्केट पे ही आप डायरेक्टली क्यों नहीं इन्वेस्ट करते? सो दैट only thing is basically the knowledge. इंडियन को 4% जो स्टॉक मार्केट इन्वेस्ट करते हैं, लेकिन यूएसए में more than 60% are investing and then earning well. So डर क्या है हमारे? बेसिकली देश से डर, और कुछ लोग सोचते हैं कि हमारे जुआ है और शेयर मार्केट इन्वेस्ट नहीं कर रहे हैं। कोई हो सकता है आपका कोई फ्रेंड किसी ने लॉस किया हो और वो उसकी वजह से आप शायद डर रहे होंगे। नाउ डर कहाँ नहीं है, हम फैको करते हैं, लेकिन मैच्योर कैटेगरी आजकल लोग फैको कर रहे हैं। क्यों? क्योंकि उन्होंने नॉलेज गेन की है अपना। जब तक आप न्यूक्लियस ड्रॉप नहीं करेंगे, प्रेसिडेंट नहीं होगा, तब तक आपके माइंड में ये नहीं आएगा कि नहीं यार मेरे को क्या नहीं करना चाहिए था और कहाँ पे मेरे को सेफ करना चाहिए था। तो दैट्स व्हाई वी आर कंसीडरिंग टू थिंग्स, कॉर्नियल एंडोथेलियम एंड पीसी रेड। दिस शुड नॉट बी देयर। तो इसीलिए फाइनेंशियल मैनेजमेंट में भी कुछ बेसिक पॉइंट्स होते हैं जो आपको ध्यान रखने पड़ते हैं। नाउ ये क्या है, जब आप कोई भी फाइनेंस कोई आप इन्वेस्ट करते हैं तो इमीडिएटली आप उसको देखते नहीं हो कि मेरा कितना रिटर्न हो गया, क्योंकि जब आप कोई भी आप सीड अगर बोते हैं तो इमीडिएटली आपको रिटर्न नहीं मिलता। इट दैट विल टेक लॉन्ग ईयर्स, और फिर उसके बाद एक पर्टिकुलर टाइम पे अगर है, उसके बाद फिर आपको डे बाय डे आपको रिटर्न अपना मिलता रहता है एंड यू विल नॉट हैव टू वरी अबाउट इट। नाउ यू कैन थिंक अंबानी कोई अपनी पे ले रहा होगा, कोई नो, ये सारा डिविडेंड से कमाता है। अंबानी नहीं, उनके बच्चे भी, उनके कोई कमाई, उनके कोई मंथली सैलरी नहीं है इनकी। दे आर जस्ट अ बोर्ड ऑफ डायरेक्टर्स एंड दे आर अर्निंग विद देयर डिविडेंड ओनली। ये 92 स्कैम जो आपको देखना चाहिए, यू विल लर्न समथिंग फ्रॉम दैट। और 92 स्कैम हर्षद मेहता का स्कैम था। आज के टाइम में जो राकेश झुंझुनवाला, राधाकृष्ण अंबानी थे प्रोडक्ट ऑफ दैट, बिकॉज एट द टाइम दे वर ट्रेडर्स बट लेटर ऑन दे बिकम इन्वेस्टर्स बेसिकली for long term. So long term will pay you. Only thing, get knowledge. There are some books you can read, some videos, some TV channels, interviews you can do it and know your power. अपने आपकी पावर को पहचाने। हनुमान जी की तरह आपकी शक्तियों को याद दिलाना पड़ता है। आपने यूजी दिया है, आपने पीजी दिया, 19 सब्जेक्ट पढ़ के दिया है आपने, और फिर 36 घंटे आपने पीजी के दौरान काम किया, फिर आप अभी भी कुछ ना कुछ कर ही रहे हो। लेकिन अगर उस नॉलेज की केवल 10% मेरे फाइनेंस नॉलेज में अगर इन्वेस्ट करते, मतलब आप करते हो स्पेंड, तो आपकी फाइनेंस नॉलेज इतनी हो जाएगी कि यू कैन अर्न फॉर योर सेल्फ ओनली। Now, share market स्टार्ट 100 से हुआ था, now it is 66,000 और आपने अगर 1980 में अगर इन्वेस्ट करता था तो you can expect कितना होगा उसका. Now, वरुण बफेट के थोड़े से रूल्स हैं, आप इसको फॉलो करिएगा, टेक एडवाइस एंड डायरेक्टली आई एम कमिंग इट कि डाइवर्सिफाई शेयर मार्केट में भी जैसे म्यूचुअल फंड में पोर्टफोलियो होता है ऐसे ही शेयर मार्केट में भी आप पोर्टफोलियो बना सकते हैं. डिफरेंट देयर सम ग्रुप्स. और आप नॉलेज के लिए क्या करना है, आप एक एक्सेल शीट बनाइए. जैसे मैथ्स में बोलते हैं कि x = 1. आप केवल पेपर पे अपने लिखे कि मैंने आज इस शेयर मार्केट में इतना इन्वेस्ट किया है और आप 6 महीने में कितना, 1 साल में कितना. आप इन्वेस्ट करने की फिजिकली जरूरत नहीं है, लेकिन आप अपने पेपर पे देखिएगा, एक्सेल शीट बनाइए एंड देन यू कैन लर्न इट. डाइवर्सिफाई जो कुछ ग्रुप्स होते हैं, बैंक के, IT के, ऑयल गैस, FMCG, फाइनेंस, इसमें डिफरेंट टाइप के शेयर्स हैं जो कि अच्छे हैं. उनमें आप एक एक सिलेक्ट करके यू कैन choose it and find deposit it. Now, criteria क्या है चूज करने का, ये है बेसिकली जो 1 by 1 फंडामेंटल कंपनी आप चूज करें जो कि वो जिस कंपनी के बारे में आप जानते हो कि वो कंपनी लॉन्ग टाइम से एग्जिस्ट कर रही है और आगे भी एग्जिस्ट करती रहेगी. जैसे ये स्टॉक्स हैं, इनके फंडामेंटल के मार्केट कैप उनकी होती है कि रिलायंस कंपनी है 15 लाख करोड़ की कंपनी है, TCS है 12 लाख की. सिमिलरली सो मेनी कंपनीज आते हैं. You can select any one company and you can deposit it, invest it and wait for long time. These companies will give you more than 30% return per year in long term. Companies should be dividend paying. These are the company Vedanta like they are high dividend paying companies. You can invest in those for long term. Some PE ratio should not be more than 25 and you can choose those companies and invest it. Even nowadays Union Bank has given maximum return because of the PE ratio was less at the time of you have started investing in it. Face value should be more than 10 because at least it should be 2 because in long term these companies will split their share. Like 10 share will become they will divide into 1, so immediately your investment will be 10 times. So this type of company you should be in your radar. Now there are some market sentiments are there on net. You can see it. Some they are 100% buy, some are 75% buy. You can choose accordingly that. You have to see in those companies foreign investors and domestic investors. Domestic investors of this mutual fund industries, they invest in share market. You can get knowledge from that. And promoter patterns, that means those promoters who have started their company and they are still living with those companies. Like Vedanta, the investors are there, promoters are leaking, their shares are pledged. That means whenever the Vedanta is earning profit, they will reduce their debt. Now, some parameters are there to select the share. Like in glaucoma, out of 3, if 2 are positive, then we declare glaucoma and start treatment. Similarly, in share markets are there in so many parameters. If maximum parameters they are in favor of you, then you can choose that stock and invest it. Then when to invest? Best time is to start today. If you have made up your mind, it is the today only, and take it for long term. Now, how much we have to invest? Start small amount in different type of different groups, and keep on investing for long term. And when there is recession, today like nowadays due to the war, the market is now at lower side. You can add more. Where to invest? ये बच्चे को पता है बेसिकली मेरे को कहाँ इन्वेस्ट करना. आप चारों तरफ देखिए, चारों तरफ के अपने हाथ में देखो, आपका मोबाइल है, उसमें जियो सिम लगी हुई है. This company is of Reliance. You can invest in Reliance. So many drugs you are writing of Sun Pharma company, supply company. You can invest in that. Indian Oil, पेट्रोल भरवाते हो आप, घर में so many DD आइटम आपके पास आती है, उस कंपनी में यूनिलीवर, एशियन पेंट आपके यहाँ है, और टाइल बाथरूम में आपके टाइल्स लगी है, वॉशरूम जब इन्वेस्टमेंट लगे. आपने कल को गाड़ी खरीदी है, पेट्रोल भरवाते हो, उन गाड़ियों में मारुति में इन्वेस्ट कर सकते हो, आप महिंद्रा में कर सकते हो. कल ही आपने एक पार्टी एंजॉय की है, ITC कंपनी बहुत अच्छी है. नाउ एग्जिट कब करना है? जब भी आपका पैसा डबल हो जाए, कम से कम अपना एक जो मेन अमाउंट आपने इन्वेस्ट किया उसको बाहर निकाल लो, और फिर जो बाकी के बचेंगे आपको फ्री का इन्वेस्टमेंट होगा एंड लीव इट। शुड बी ऐड, अगर मार्केट हाई है तो आप कर सकते हो, यस, क्योंकि जब आप इन्वेस्ट करते हो तो पहले के मुकाबले आप ज़्यादा ही अर्न करोगे, लॉस में कभी नहीं रहेगा। Now ITC is a good company. Now Reliance is now at lowest point. Now you can start your investment in Reliance and you will never be in loss. Now PNB ऐसे कोई न्यूज़ पढ़ते रहना चाहिए आपको, न्यूज़पेपर में they will give it, because now PNB share is now increasing day by day, because जो इसके NPAs थे वो कम हो रहे हैं और धीरे धीरे करके इन्वेस्टर्स का जो ट्रस्ट है वो PNB में बढ़ रहा है। एवरेज इन विप्रो का आपने बताया क्या है, जब आप स्टार्ट करते तो 480 पे था, एंड नाउ इट इज डे बाय डे हमने इसको ऐड करते चले गए, नाउ इट इज 401। तो इस जैसे आप इंक्रीज मतलब इन्वेस्ट करते चले जाओ, एवरेजिंग कम होती चली जाएगी। ओनली थिंग इज जब भी मार्केट लो हो आप उसमें ऐड करिएगा। नाउ ये प्रिंसिपल है कि जब बाजार में अगर करेक्शन हो तो आपको खुश होना चाहिए कि नाउ इट इज माई टाइम टू इन्वेस्ट। और वो विप्रो का एग्जाम्पल मैंने दिया था, जब हम 10,000 इन्वेस्ट किए थे तो 100 शेयर लिए थे इसने, धीरे धीरे करके उसका स्प्लिट हुआ, बोनस मिला, और ना उसके पास 2,56 लाख शेयर है, और अब 400 के हिसाब से आप लगा लीजिए कितना, इट इज मोर देन 1,000 करोड़। तो दैट इज वाई जो भी बंदा पैसा इन्वेस्ट करके सो जाएगा, बिल्कुल लेजी होगा, वो मैक्सिमम कमाएगा मार्केट। ये प्रिंसिपल है, इसलिए बार बार मत देखो जस्ट, क्योंकि आप गोल्ड खरीदते हो आप कुछ नहीं देखते भी कल कितना हुआ, आप प्रॉपर्टी खरीदते हो कल को नहीं देखो कितने का, लेकिन लॉन्ग टर्म आप देखोगे कितने का हो गया। इसी बच्चों को आप लॉन्ग टर्म में बाद में मिलते हो 20 साल के बाद, तो आपके माउथ से क्या निकलता है, अरे इतना बड़ा हो गया। तो सिमिलरली इट हैपेंस इन योर इन्वेस्टमेंट। सो समरी इज मेक अप योर माइंड and all these things, stay invested and enjoy profit, and अपने पेरेंट्स से जरूर सीखिएगा प्लीज। आपकी जो मदर है, आपने मतलब उसको मार मार के आपको पढ़ाया है, बच्चा ये खा ले, ये पढ़ ले, बाहर मत जा, और अब उसकी वैल्यू जो है क्या है, हम सब आपके सामने बैठे हैं, बिकॉज ऑफ एजुकेशन यू आर अर्निंग वैल्यू विद द मेन दिस थिंग। नाउ हैप्पी इन्वेस्टिंग एंड थैंक यू वेरी मच।
Thanks. Happy investing. Happy investing.
आप वैसे एक छोटे
of the year or the सर्वश्रेष्ठ विद्यार्थी, as it was said. इसको चला देना presentation. So we have 5 residents who were chosen after the prelims. So Dr. Megha, are you there? Dr. Rishabh, Dr. Sapna, Dr. Vanshika, she's Dr. No, you will be there. आयुषी कौन कौन है? टीओटी तो अब इसके बाद होगा ना, इसके बाद होगा। एंड सपना, जस्ट कॉल देम वंस। So I would like you to sit in the front. I mean, one here, one there. That's okay. And you don't have much support for you guys, it seems. I thought there would be prompting from behind or forward. So you guys are again on your own. It seems that the paper was really tough. I didn't realize that it's getting really tough. The theory paper was actually tough. Yes, they had MCQs.
But I'm glad to see women power in residence. Where we residents, people also, there was one boy and there's 4 girls. 4 girls. Yeah, also 4 girls. And also, you know, from a teaching experience, I was always the girls are very sincere also, and very sincere residents.
Ayushi, if there is no response from these guys, I think we can move forward with these 3 guys. Sir, already we are 20 minutes late now. श्रेष्ठ विद्यार्थी 2023. So we have Pawan Chore sir, Nepalia sir and Sudhir Singh sir as our judges. So let us first know the rules. The questions may have sub-questions, and to qualify for full marks, you need to answer all the sub-questions. Each question will carry 10 marks. There will be no marks for half answers. 30 seconds will be given after we read out the question. And there will be no passes, no negative marks here, because I think we had a significant negative mark in the theory paper. And for next half an hour to 1 hour, we are going to have, kind of, this is the word we'll be finding. And the last round will be an extempore. So since it's a kind of topics written by the jury, so we'll increase the marks out of 20 rather than 10 here. So I'll written here 10, but it's going to be 20. So you will have 40 for the questions, which will be in the 4 rounds, and then 20 marks for the extempore, right? So extempore, you will be given 30 seconds to think about it, and 2 minutes you will have to speak on the mic with the topic whatever is being given to you. So let us start with the round 1. This is going to be a short story. So I am going to start with Megha. So Megha, the question is, a 12-year-old boy presented with acute motility restriction, pain in upgaze associated with upper lip swelling and mild ptosis. Sonography of the orbit shows hypoechoic lesion in the superior rectus muscle with central echogenicity. The most likely diagnosis is, time starts now. So we will be given 30 seconds, there will be a buzzer out. Myocystic sarcosis. So 10 marks for Meghna. So the answer is absolutely right, myocystic sarcosis, because the central echogenicity is showing with the squalex here. Second question is to Rishabh, a 5-year-old female presented with acute proptosis, chemosis, restricted ocular movements. She appears lethargic, pain, history of recurrent fever, hemogram reveals anemia and leukocytosis. Which could be the following, which would be the most appropriate investigation? Peripheral blood film. So he also gets 10 marks because here we are looking in for blood risk areas. This goes to Sapna. A 42-year-old male presents with progressive painless axial proptosis, visual acuity 6/9, 6/6. MRI orbit shows well encapsulated homogeneously enhancing mass with contrast in intracoronal space. Most likely diagnosis is. Time starts. Optic nerve meningioma. So she doesn't get a mark, she gets a 0. It's a cavernous hemangioma, which is a typical picture of cavernous hemangioma. Now we move on to Vanshika. A 4-year-old male presents with rapidly progressive abaxial proptosis of the right eye associated with downward displacement of the eyeball. Imaging reveals homogeneously enhancing mass in the superior orbit. The intraocular and systemic examinations are unremarkable. The most likely diagnosis is orbital rhabdomyosarcoma. That's right, that's a kind of inflammatory malignancy. Oh, I'm sorry. So she also doesn't get a marker rating? Okay. So the correct answer is orbital rhabdomyosarcoma because this is one of the inflammatory tumors, highly malignant. Now this is for Darshana, a 31-year-old female presents with sudden diminution of vision, right eye for 15 days. There is mild subjective improvement over last few days, mild ocular pain, exacerbating on eye movements, vision of 1/60 and 6/6. Right RAPD, anterior and posterior segment unremarkable. The probable diagnosis is. Time starts now. Retrobulbar optic neuritis. So after round 1, I think we have 3 of them with 10 marks. Megha, Rishabh and Darshana. And other 2 are yet to open there. So now we move on to the round 2, which is of pictures. So this is for Megha. Identify and how it is diagnosed. Time starts. Those 2 black marks are on the screen, okay? Not to consider these 2 black marks. So 30 seconds are over. So this is optic nerve hypoplasia. There is a double ring sign, and you have to take the ratio of the horizontal optic disc versus the distance between the temporal disc and the fovea, and it should be more than 0.35 normally. This was a tough one? Okay. So we award her 5 marks or? No, I don't have other questions. So we'll see, sir. Let us see. We can. This picture was not good. Okay. It was not very typical of optical. Okay. So maybe we can give her marks on the jury's recommendation. 10. Okay. So we move on to the next question, Rishabh. Identify and how to manage. Your time starts now. So Rishabh has given up. So this is neuroretinitis. It presents like a triad of optic disc swelling and macular exudates. You have to find out the underlying cause, if any, and you have to plan steroids. Okay. This is for Sapna. Identify and how to manage. Time starts now. So I think सबके लिए difficult है शायद. You have to identify the line which is shown here.
Thank you very much.
No. So this is what is called as Khura-Dost line. It's a line for endothelial rejection. You can see it's a post-PK patient where the PK has been done. And for managing endothelial rejection, you have to plan it like an emergency, adding oral or IV with topical steroids. Now the next question is to Vanshika. Identify the last or the posterior most angle structure seen, abnormality of the scene and the significance of the scene, whatever you see here. Yes? You have to identify, answer both the questions. First, what is the last or the posterior most angle structure seen? And ciliary body band is seen, and what is the abnormality? So you're right that what we see in the end is the ciliary body. That's true, but these are goniosynechiae, not peripheral antisynechiae. So peripheral antisynechiae is pretty wide based, and what they show us is the kind of angle closure component here, even with the open angles, and this is an indication for a YAG PI. You can also identify blood in the Schlemm's canals, which I thought would be a kind of a bonus if you give, but so I think you don't, because you're not answering the full question. Now this is for Darshana. Identify the cause and the disease in which they are seen. वो पूछा कि लॉक किया जाए, लॉक करने के बाद फिर चेंज नहीं कर सकते हैं, राइट? So these are very typical of primary congenital glaucoma. They are Harp style, and they are linear tears in the desmal membranes. They are not desmal membrane folds. Desmal membrane folds would be a sign of hypotony, right? Or maybe corneal edema. So after this, what should we do? We should award the marks to Megha, or should we retrieve back the marks, because none of them could answer the picture round, I guess. No. पाँच सबको दे दो. So Now we move on to the round 3, which is going to be mixed bag. So this first question is for Megha. Identify the defect and where is the lesion? This is actually pie in the floor. Okay, because it is in the inferior part. So this is pie in the floor. You are partly right, but again, as I said, we have to answer the full question. And the lesion would be in the parietal lobe. It's a left homonymous inferior quadrantenopia, which is called as pie in the floor, and the lesion has to be in the parietal lobe. Sorry. We move on to the next question for Rishabh. A patient presented with fields in his seeing eye and the other eye is PL negative. Name the scotoma and site of the lesion. Nasal step. How much time left? 17 seconds more. So this is a junctional scotoma of Trochwell. This is involving the von Willebrand's leaf, which is this part, because these fibers from this area go anteriorly and then go back. So if the lesion is around here, or it's a post-fixed chiasma with pituitary tumor on one side, then you can have PL negative of this optic nerve and then having the supratemporal quadrantenopia of the seeing eye. So I think Rishabh also doesn't get a mark here. This is your question, Sapna. Diagnosis, risks and treatment for this patient. So Sapna, this is retinal vein occlusion, and we can see all quadrants hemorrhages with vascular occlusion. There are large areas of choroidal non-perfusion with macular ischemia here seen. So this is a patient who has a high risk for development of neovascular glaucoma, and pan-retinal photocoagulation is what is required in this patient. So this is a question for Vanshika now. Diagnosis and the cause. You know, then it becomes little heterogeneous. Should not. I don't think it's very difficult. It's not actually the inferior oblique palsy. You have to look, kind of in clinical situations. So this is a Brown syndrome. It's a tight superior oblique. So what you see here is that this is aligned here, but it goes down on dextroversion. So it's a left eye which is abnormal. That is correct. But this is left Brown syndrome. In fact, Brown's plus because it is going down. So. So next question is for Darshana. Diagnosis and how to confirm it. 30 seconds. So if you look at it, like this is little high, and the dextro version, this goes further up, and on dextro elevation it is pretty high. So it's a superior oblique palsy of the left eye, and you can confirm it by Parks-Belchowski's 3-step test, and this is a 3-step test where you can see the elevation increases here but decreases on this head tilt. So I think this round also goes with 0 marks to all. These are, I think, all the questions which, yeah, SO palsy, retinal vein occlusions, Brown syndrome, and
exam question.
so only optic nerve hyperplasia was the one which was little difficult for you as per the jury. So now we move on to a little fun time. So these are the riddles. This is the last round for the quiz. They are riddles, and so these are the riddles. They will talk about a phenomenon, a part of the eyeball, or some disease. You will have to pick out what this riddle is talking about. So this question is for Megha. I am a condition quite rare, you see, when one's eyelids don't quite agree. When I am present, a curious sight it makes. Along the mouth, the eyelid shakes. Name of a doctor who did first proclaim the syndrome and gave its famous name. That's absolutely correct. So this is Marcus-Gunn syndrome or Marcus-Gunn jaw winking phenomenon. So the next riddle is for Rishabh. In the world of eyes, I am unique sight, a peculiar that might give you fright. One pupil constricts while the other does not. It's a phenomenon that can leave you in thought. Named after Marcus-Gunn, I am a peculiar way to test the optic nerve and its decay. This is actually Marcus-Gunn phenomenon, which is different from RAPD. Anyway, sir, should we give this marks? ज़्यादा confusing इसलिए दे देते हैं चलो. This is for Sapna. In the realm of vision, I cast my spell, affecting the eyes, a tale to tell. Double vision and drooping lids are the symptoms that this condition forbids. Outside the eyes, I am less inclined, primarily in ocular muscles you will find. What am I? The vision condition is so keen, with ocular muscles I intervene. You have an option which is saying that outside the eyes I don't kind of go. So third nerve palsy can have systemic manifestations. So there is a specific thing which is written here. So कुछ तो फन करने के लिए विशाल ने कहा तो मैंने कहा चलो. So this is ocular myasthenia. So all kinds of palsies can come with myasthenia. So it was specifically written here that outside the eyes I don't go. So this is ocular myasthenia. So we move on to Vanshika now. I am an inflammation, a sight in distress. In the realm of vision, I cause distress. Blurred vision and colors that fade. An optic nerve battle. The cause is laid. Associated with conditions, multiple or not, a challenge for eyes as we have surely thought. A temporary condition or a long-lasting fight. What am I? Long losing one, had a sad plight. Optic neuritis. That's correct. This was simplest. So we move on to Darshana's question. As the years go by, my presence grows. In the center of vision, my story shows. I lead to blurred vision, making tough to see, especially for things that are right in front of me. It may be gradual or sudden, you see. What eye condition am I affecting your visual screen? It says you're not able to see what right in front of you. this line. So this is age-related macular degeneration because it typically affects the central vision and increases with age. Yes. So this finishes with the quiz round. Now after the 4 rounds, we have Megha with 25 marks, Rishabh with 25 marks, Sapna with 5, Vanshika with 15, and Darshana with 15. So the next round is of 20 marks, and you'll have to pick up a chit, and you'll be given 2 minutes now. Once I start, you'll be given 2 minutes to present your extempore. So I'll start with again Megha. So what she gets is AD's pupil. So you can now just think of Darshana. 5 seconds, and then you have 20 seconds के बाद 2 minutes. So think about it for 20 seconds. If you want to write something, you can write. Okay. We are going in the reverse way.
You're given some time to collect the choice.
Yes, 30 seconds.
30 seconds. It's an word.
So, ED stonic pupil. In ED stonic pupil, it is a condition in which it is a defect of the pupillary pathway, and so in this the parasympathetic nervous system is affected, and so the pupil, on examination we see that the pupil is dilated, and so accommodation is retained in this, and so the condition in which we see AD stonic pupil is so it can be associated with neurosyphilis. So that's it.
Right. So thank you, Darshana. We move on to Vanshika now. Scope is nodules. Scope is nodules. Scope is nodules. So she has 30 seconds of thing. She is Vanshika.
Coppes nodules are seen in uveitis. Uveitis is the inflammation of the uveal tissue. It can be of 3 types: anterior uveitis, intermediate uveitis, and posterior uveitis. In cases of anterior uveitis, 2 types of nodules are seen. First is Coppes and second is Busacka's nodules. Coppes nodules are seen at the pupillary margin, mainly composed of antigen-antibody reaction. They are formed. Busacka's are found at the root of the iris. This is the difference between 2 types of nodules, and basically, it's a pathognomic feature of the anterior uveitis.
She gets sunflower cataract.
This is seen in Wilson's disease psychosis.
So we move on to Rishabh now. Bell's phenomenon.
So Bell's phenomena is a phenomena in which there is a normal phenomena to protect the eyes. In which the eyes goes up and out when we close our eyes. It is a protective phenomena. It has two alternate types of inverse well phenomena and reverse well phenomena. In inverse, the eyeball goes up and inside, and in the reverse phenomena, it goes down and out. Mostly in case of ptosis, we see when the upper eyelid doesn't close properly, there is a chances of exposure keratopathy if the patient has a poor comprehensive health.
So last is Megha. She gets pseudo exfoliation syndrome. You have time. We have well things to think about it. We have time to time well this.
Position of dandruff-like material. It can either be seen on the anterior capsule of the lens, in the iris, like pupillary margins, and in the zonules also. In pseudo exfoliation, if we do cataract surgeries also, it's kindly difficult because during cataract surgery, the zonule gets weakened. So that is the thing, and it is seen majority in glaucoma patients. There are two types of exfoliation. One is pseudo exfoliation, one is true exfoliation, and
So this finishes all the 5 rounds, and we'll just sum up the marks of the judges, average them, and add to the average right now.